फिर उसकी जरूरत नहीं, लेटर ही नहीं करना, ये ले चल रहा तो कुछ नहीं है। अब देखो आ रही हूँ। पूरा ऐसा आ रहा है तो पढ़ रहा है फिर आएगी नहीं चलेगा। चल
A very good morning to all. We'll be starting our ceremony and CME in another 5 to 7 minutes. Thank you. A very good morning to each and every one of you. It is with great pleasure and immense pride that I welcome you all to VMMC and Safdarjung Hospital for this significant event focused on adult vaccination. Today's CME is a testimony to our commitment to holistic healthcare and a future where communities and ecosystem thrive without the spectrum of preventable diseases. This occasion serves as a powerful reminder to our shared commitment to eradicate preventable diseases that had affected the humanity for way too long. We have heard so much about adult vaccination, and as the time is progressing, it is becoming even more important day to day, and it is very important for us to bridge the knowledge gap that exists. Throughout the day, we will have the privilege of hearing from distinguished experts and leaders, which will help us upgrade the knowledge and give us the rightful insight that is needed. So I encourage each one of you to fully engage with the session, ask questions, and foster discussions. The knowledge and experience shared here today will be instrumental. Dr. Rajat was Program and Technical Manager for GAVI, G-A-V-I, founded for RISE project. Between 2011 and 2019, Dr. Rajat worked as SMO under team management, plan development, and
Association of Epidemiologists. So in the recent years, as we just heard, we have witnessed a significant, increase in concerns among the public health community regarding adult vaccination. And so many examples we are already aware of: hepatitis B, HPV, chickenpox, so on and so forth. So adult vaccine preventable diseases among adults has emerged as a very important issue, and so there are multiple reasons for it. So the first important reason is that there is an epidemiological shift, we are all aware, in the diseases, in the age distribution from early childhood to adolescence and now among adults. The second important issue is the waning immunity among the adults, which we have also been looking at. And the last is some phenomena, a very important concept called immunosenescence, which is the association of age, elderly, with immunity. So that is there. So regarding the data on adult vaccination, we can definitely say there is a lot of paucity of data among in Indian community regarding the incidence of VPDs among the adults in India. So past decades, in the decade, we have seen some of the data on few VPDs like HPV, hepatitis B, and even some data is there on diphtheria outbreaks. So that is there. So now India, as of now, we have multiple recommendations for multiple diseases. Like you have health workers, among health workers, hepatitis B, then among pregnant women, some of the examples. So now, we really don't have any nationally adopted, guidelines. So we definitely need a national commitment as of now. So in India, we see this is an important concern. So about more than 2/3 of the adults, they are as of now not aware of the adult vaccination. So we definitely need to work on things like IC. We need to work on the surveillance of VPDs and as we have discussed, the national guidelines. So we need to work towards this commitment of national guidelines on the subject. So in the end, I just want to mention one more, the very important approach which is mentioned and which is supported and which is stressed upon by WHO, which is a life approach in immunization, which is a very important framework to help the public health officials optimize the health, across from lifetime, from early age to the elderly. So that is very important. Some of the interventions which will come in this are the catch-up vaccination at recommended age and booster dose. So this is what it is regarding the topic. Further ado, I just want to move on to the welcome address. I would like to acknowledge and thank all the dignitaries of the dais and on the dais who have joined us today. I would like to thank our MS Madam, Dr. Vandana Talwar, and our principal, Dr. Gitika Khanna, to extend their support and allow us to do the program today. Our guest of honor, Dr. Prem Kumar, Senior CMO, former additional MS. Thank you, sir, for taking out time on such a short notice. Our Dr. Rupali is here. Thank you so much for coming on a very short notice. Dr. Rupali Roy, Joint Director General, DGHS. Dr. Jugal Kishore, sir, Director Professor and former Head Community Medicine, Vardhaman Mahavir College. Sir is instrumental in bringing everything together and leading us in this program. Dr. Y.C. Porwal, Professor, Professor and Head Medicine, Vardhaman Medical College. Dr. Pratap Singh, Professor in Medicine. Dr. Rohit Kumar, Associate Professor, Head Associate Professor, Obs and Gynae. Dr. Avneet Kaur is, I think, we are expecting her. Additional professors, CCM, AIMS. Dr. Rinku Sharma, we are waiting for her. Joint Director and Head, NVBDCP, DGHS. And Dr. Sneha Ranjan is here from the department. Thank you very much.
Now I would request Jugal sir to facilitate the first part.
Yeah.
To facilitate Dr. Prem. Please put a round of applause. Next, may I please request to facilitate Dr. Rupali. Next, may I please request to facilitate Dr. Rajat.
Good appreciation.
May I please request Shalini ma'am to come up on the stage once again. May I request Shalini ma'am? May I please request Dr. Rajat to say a few words, come upon the dais and please say a few words.
Thank you, Dr. Jugal Kishore, dignitaries on and off the dais, for giving me this opportunity to be a part of such an important event. Over the last few years, we've seen the importance of adult vaccination. Although it is very important, but we can see for decades the government of India is prioritizing about childhood vaccination. We've been reading about childhood vaccination from very long. I almost spent a decade. We learned bits and pieces about adult vaccination, but in childhood vaccination, because the government focus was on reducing the mortality, the IMR, the under 5 mortality rate. So there was a lot of focus on childhood vaccination. I would like to share a small experience when I worked as a surveillance medical officer in NPSP WHO. I read a lot in theory about the importance of vaccination, about the importance of vaccines, about the importance of data, like what Madam said, how this data, how research is important, and we need to have data regarding adult vaccination, the prevalence of vaccine preventable diseases among adults. Because when I went to the field and I saw that there were cases when I worked as a surveillance medical officer in NPSP, there were a lot of deaths due to diphtheria in UP almost around 2015-16, the National Polio Surveillance Project, they started supporting the government for this vaccine preventable surveillance for vaccine preventable diseases like diphtheria, pertussis, neonatal tetanus, and we started getting a lot of cases. A lot of cases were being reported of these cases, and what we did was we linked the reporting of these cases to surveillance, active surveillance, as well as to vaccination. And you see, we found a lot of cases in communities. The communities were, you can say, there was a lot of vaccine hesitancy in those communities. But once the community, they knew that this is a death and this is a death due to vaccine preventable disease, the same community I told you, when we sent the vaccine, then there was shortage of vaccine. They call their relatives that you should bring your children, they need to be vaccinated because there are deaths happening because of this disease. So there is a need to have data, similar data for adult vaccination as well, for the prevalence of vaccine preventable diseases among adults. And I think this is a very good forum about updates on this adult vaccination, because I think there is we need to be updated as medical practitioners about the different vaccines which are available and what are the schedules. And I think maybe this can be one of the step in policy formulation as well, because government policy always needs data research to formulate and to allocate resources which are always few, and there is a lot of demand. So I hope this update, this CME is a big success, and I would like to again thank the organizing committee for organizing such a great event. Thank you.
Thank you so much, sir. Now may I please invite Dr. Rapali to come upon the stage and say a few words.
Good morning, everyone. Thank you very much, Jugal Kishore sir, Shalini ma'am, for giving me this opportunity. Now I am working in the Director General Health Service as Assistant DG, but today here I would like to represent myself as a General Secretary, Indian Association of Epidemiologists, which is one of the collaborative partner for this seminar workshop. And I know Jugal Kishore sir always organize such kind of seminar or workshop on the topic which are really important at present days. So I would like to congratulate sir and his team for organizing this function. And regarding Indian Association of Epidemiologists, I know here today students, UG, PG and nursing students are there, and who are in the community doing PG in the community medicine. They are all eligible for being member of this association. So you may contact Jugal Kishore sir, so you may become the member of Indian Association of Epidemiologists, because this is one of the technical association which always organize such kind of technical activity, and you will be keep on updated. We have one official journal also under the leadership of Jugal Kishore sir. So you have the opportunity to publish paper in that journal. So otherwise, if somebody is not from community medicine and doing PG in the other subject, they are also eligible if they have some public health background, at least for epidemiology background, 3 to 5 years experience working in the public health program. I know the whole day you will learn about adult vaccination. There are distinguished speakers there. I won't talk about the adult vaccination. So I hope you will have a great day ahead, and you all queries and questions will be answered at the end of the day. Thank you. Thank you.
Thank you so much, ma'am. Next, may I please request Dr. Prem to come up on the stage and say a few words.
Very good morning to all of you. I'm very happy to such a large gathering. First of all, I want to congratulate Dr. Jugal Kishore and his team for organizing this update on vaccination of the adults. मैं एक बात कहना चाहूँगा, डॉक्टर जुगल किशोर की जितनी तारीफ की जाए उतनी कम है. तालियों से इनका स्वागत है. In past also, I have attended many programs which are being organized by the community medicine, and they are really very wonderful, highly enriched in the knowledge. Recently, in COVID, we have learned the importance of the adult vaccination, COVID-19 vaccination. You must have heard, because of this vaccine only, so many lives were saved. So tomorrow, in the coming days, there may be some other disease. And it is the Dr. Jugal Kishore who has advised me for flu vaccine. I took it from community medicine itself. Thank you, Dr. Jugal Kishore, for giving me this advice. Moreover, I will say that vaccination is not only required in the childhood, in the after birth, but in the adult, because hepatitis B is so common, typhoid, not tetanus and diphtheria. Now there is more and more awareness of this vaccination. So I will say that this program should have a very good thinking of area of the vaccination, and you all should spread the awareness of the vaccination. And I wish all the best for this program and grant success. Thank you very much.
Yeah, very good morning. Thank you for your high words, and I'm always grateful the support of my seniors. The senior from my UT time. So you can see that the bond which is there always remain. So always appreciate your colleague. Never leave them, because they will be there standing all the time, even in your old days. We had this research grant sponsored by our Indian Association of Epidemiologists. So we had the national conference, and there it was presented, the proposal was presented. So we were finding how we can hand over the grant to the successor. Now actually, beside many oration and also the awards, this organization, I'm the vice president, Dr. Anil Kumar is the president, Dr. Rajat is the treasurer. So many of you are actually member of our organization. The purpose is to increase the skills required in epidemiology. That's the purpose. And I think epidemiology is a core of community medicine, core of medicine. Rather, all subjects has to have the the concept of epidemiology. That is why this is well recognized. I think I got the call from Denmark and also France during the COVID to represent Indian epidemiology during the to say about it. So I have come on the TV, in their TV, when we had the video conferencing. So that's the value given not only by Ministry of Health, but also by our the international bodies. And international organization of Association of Epidemiology also recognize it. So it's always privileged, and I think proud for the Indians to be part of this organization. Although we have many organizations, they are providing the free registration, but I think the small amount is given. Then only you are legally become the member of any organization. It cannot be free and should not be. So this award is actually known as the research grant, and that was decided by the committee, and it is around 40,000. So the criteria is actually he or she should be the young epidemiologist, should be member of IAE, and the proposal is submitted in a prescribed format, presented to the committee in maybe, I think, in some kind of organization conference or workshop. Then it is selected by various contender will present the that research, and the marking will be given on the basis of outstanding presentation, originality of the research project, robustness of the study design, and effectiveness of the style. And last is actually that the report has to be submitted once the grant is given to you in the form of a published article. So these are the criteria by which it has been. So we had around 6 contender, and they presented in front of us, and then it was selected. The highest mark was given to Dr. Sunanda Gupta. She's our senior resident. So I congratulate on behalf of our organization. We want to hand over the check of 40,000. So I request our General Secretary, also Dr. Prem and Treasurer to hand over, and somebody can take the picture of our beautiful lady, Dr. Sunanda Gupta. Please.
Heartiest congratulations, ma'am, from all of us. I would like to thank all our guests of honor for taking out their precious time and being a part of this CME. With no further delay, I would like to inform everyone that before we start with our sessions, we have shared a pre-session questionnaire, which we would like that you fill right now. It won't take more than 5 minutes. Once you fill that, we would start the sessions, and after the sessions are over, there's a post-test questionnaire as well. So can we please take 5 minutes, and can I request all of you online and in the link is on the group. Thank you so much, ma'am. Thank you, sir.
they have already saved, a lot of life, and it's a cost effective. This is actually a systematic review. You know that, number of research is published, and then somebody is compiling, the conclusion of those all results in a combined manner. So they are very good in policy making. So it has been found that this is cost effective. You can see that how much cost effective, how much quality is saved by the vaccination. And this is a good, number of paper published. It says actually the influenza and pneumococcal, the Haemophilus influenza, the papilloma virus, and herpes zoster and tetanus. So the saving is very evident when we say the influenza and pneumococcal, and to some extent the human papilloma virus, as compared to tetanus or zosters, where the range is quite high. So number of study has been published and showing a very good evidence that they are, cost effective. You can see that already we have seen the impact of traditional vaccine like the diphtheria, pertussis, tetanus, and polio and measles. And now many people are now advocating, and it is now in practice, of influenza vaccination, rubella, hepatitis, Hib, typhoids, cholera. Similarly, the rotavirus is already now part of the vaccination schedule. We have the HPV vaccine now. The gynae people are going to come and talk about it. So this is also found to be very useful. Meningococcal is also part of our the children vaccination. So you can see that they are very promising type of vaccine, which are already now accepted by the government, and they will be the part, and they are actually part. Now the next move is on malaria vaccine. The research is already over. It is already started in South Africa. We'll talk about it more. Similarly, dengue vaccine is there. TB vaccine is also started in some of the districts. So you can see that these are the future of that, how even the person who are in contact with the TB, can we protect them? That's the, future. So we want to prevent, and that is the public health. Public health is more of a prevention. We are, selecting the strategy which can be more cost effective, much better than the treatment as such. So that is what we found. It has a long history, I've already said. One should not doubt on it. The reason is, this is tested in human population. Even the COVID vaccine, it's a crores of doses are given. And if 100 case or 200 case of some, complication has occurred, should you call it as failure? Not even 0.00001% side effect is observed. I said to the reporter, dear friend, if you inject the water, you'll find more side effect than, such vaccines. But, you have a lot of hue and cry. If your question is wrong, like if you have a question that do you have the pain or a fever, I'll tell you the pain will be 100%. After vaccination, do you have a pain? So it's the way by which you are going to get the side effect or maybe complication. That's not the question, should not be question. Injection लगाएंगे पेन तो होगा ही, 100% किसको नहीं होगा, लेकिन उसको कंसीडर करना कि नहीं दिस इज रॉन्ग, ये होना नहीं चाहिए. तो ठीक है, we have to develop the nasal or some, even the nasal is also not very, without any side effect. So the point is that you have to compare with the effect, compare with the benefits. One should not go on the simple thing of some complication. So it has a history of, 200 years, over a period of time, so many vaccines keep coming and we have developed. Some may be failed, some may be, under experimentation, but we can't say that we are failure or something should be. No, this is one of the tool which we have, created. We should be, working on how we can make it best. So it's already known, I think you all know that this is the way the things are happening. That is why the adult vaccination is important. Initially, if you give a 1 dose or 2 dose, you have a, if the antibodies production will increase, but because of the waning effect, the antibodies level will go down. But the body, our human body cells, they will never forget. They will always keep something in the body. So when you have a second dose or a booster, the effect would be flaring up. And that could be one reason that we have the many diseases which are having, a lot of crisis. Even, we have the crisis of like dengue is the example. If you have one infection, the second infection, you will have a more problem. Second and third infection will be having more, because the antibodies, become the self, destructive. So the best is the people were saying, no, the natural infection is much better than the vaccination. Vaccination will not produce that kind of effect which the natural infection is going to have the adverse effect more. Okay, that is why the vaccine has a very calculative, effect, maybe a less effect, because they are killed viruses or maybe bacteria or whatever. They are in a very small dose. So in some, we require multiple dose, to bring it back to the, normal effect. So one has to see that which kind of infection we are talking about, where we require one booster, a second booster, or many boosters. That's all depend on the kind of the virus or bacteria we are talking about. Unfortunately, we have a lot of barriers. Healthcare providers themselves are not very receptive of the vaccination. That's a problem. We have a lot of myths and belief systems, and that is not because of their study, because of their culture, because of where they are, and because of their other influences. They never actually read the core concept of immunity. That's maybe the problem. If you really learn the physiology and biochemistry properly, the medicine, you will learn that what is going on in the in the body, and what pharmaceutical product can give rise to effect and kind. We are moving towards the nanoparticle mediated effects. It's very nice that we are now having the vaccine answers. They are already there. So we are reaching to that level, and still we are doubting. That's not good. So one should try to learn, where we are not able to understand these things. Efficacy and safety of several vaccines used for adult are actually, again, they say that it's not good. Like COVID vaccine. Every second day the news is coming, नहीं ये खराब है, नहीं खराब है. अरे पूरा वर्ल्ड में सब लोगों ने वैक्सीन लगवा लिया, आप ये कह रहे हो खराब है. So that's not the case. Believe that vaccine is meant for children. That's again. So everybody think नहीं बच्चों के लिए, बड़ों को क्यों देना है? बड़ों को तो कोई प्रॉब्लम होती नहीं. लेकिन जो उनको प्रॉब्लम होती है उनके लिए वैक्सीन हैं, उनको और कम होंगी, है ना. Adult vaccination is selective, so not universal. सबको नहीं चाहिए, ये एक और प्रॉब्लम है. सोचते नहीं जो बीमार रहते हैं या जो मे बी आई थिंक उनके लिए. No, vaccine protection require everybody. Otherwise how you are going to develop the herd immunity? How you are going to be protecting a larger population? Healthy adults are harder to reach through the public health because they are always in, their offices, their, workplace. So going home is difficult. So we have to tap the other areas, like maybe hospital, maybe I think somewhere in, workplaces. We have to go there and do the vaccination. So a lot of efforts are required reaching to adult. That could be another reason. Why adult vaccination? I think I've already described a lot about it. So fortunately, we have now the very good established public health system. We have health. We have the primary health center, community health centers. We have the very good cold chain machinery, which is better than even privates, So we should use that machinery which is created over a period of time. Then we should see that already, I think 90% of our population in under 5 is now covered. In many places, there are lagunas. I agree with that. There are reasons for that. So covering those all things where the vaccine is already covered a large population, we should move towards now bigger population. That is the adults and geriatric population. They are the one we should be getting the benefit of. And we have a sufficient evidence that adult vaccination is beneficial. Okay. Booster protection acquired by immunization earlier in life required, natural immunity, so you can have later on. So that is another one, that if we can have even booster, I think, and some of the booster is coming like pertussis or same like measles or rubella, or maybe adult life, maybe zoster, herpes zosters can be given later on. Pneumococcal vaccine can be given. Hepatitis, another example of booster effect. So we can definitely eliminate the disease through constant efforts by our machinery which is already there. Then it also, like, when you are traveling, when you have a high risk behavior or you are immunocompromised. And today we are going to talk a lot on when patients are coming in our pulmonary OPD or CKD, or maybe some kidney disease are there, what vaccine can be given so they can be more protected. So when we have that, medicine, why not? Or why we should not protect them? Now this is already known that we follow the, CDC, and CDC has very nicely given 26 year what vaccine should be given in 27 to 49, 50 onward. OPD, like in preventive medicine, all 50 years of all health workers, whether they are, class 4, class 3, or nurses or doctors, they can come and get the hepatitis influenza vaccine. They are available, and we are trying other vaccine how they can come. So I know that our health workers are the one which should get the all, measures, because they are in profession where the risk is quite high. And very soon we are going to have a reverse this policy of including MMR as a second dose also, not just a first one, but second dose also, because mumps is not just inflammation of your parotid or maybe these glands, but also affecting to your fertility, reaching to your so that should also be considered. So whenever it is not a piggyback, just a small component can be added to, which without any much cost can increase the probability of decreasing the incidence of disease. So that's one method. That, and similarly, like we had the pentavalent vaccine. So we used to give 3-4 vaccines. Now one vaccine can have 5 ingredient. So that decreases the suffering of the child. So that's all what I think this policy decision should change, and we are working on it, that how it can be changed.
Thank you so much, sir. Can you please have a note, sir? Thank you so much for giving so much information, explaining the topic in so much detail, addressing so many doubts and concerns, all in such a concise manner. May I please request Dr. Shalini to felicitate sir with the memento. Dr. Shweta. I would request all our respected speakers, since we are a little short on time, to keep the lecture for not more than 15 minutes. We'll keep 5 minutes for question answers also. Next, may I please request Dr. Rohit Kumar sir to deliver the next lecture on vaccines in chronic lung diseases. Sir is an associate professor and head, Department of Pulmonary Medicine, Critical Care Medicine and Sleep Disorders, VMMC and Safdarjung Hospital. Sir is MBBS, MD and DNB Medicine, DM Pulmonary, Critical Care and Sleep Medicine, MSc Endocrine and Diabetes Mellitus. Along with this, Sir has various other degrees which include MNAMS, MRCP UK, and he's also a Commonwealth Scholar. Please put a round of applause for Dr. Rohit Kumar, sir.
Thank you, everyone. I will be talking about vaccination in chronic respiratory diseases, but I will be specifically limiting myself to just two vaccines actually. I'm avoiding COVID right now, but I'm going to specifically limit myself to influenza and pneumococcal vaccine. So just this question that was asked during my MBBS days was, what is the difference between vaccination and immunization? And what I used to do was I used to assume that they're the same. But just revising since I'm coming to this college block, I just wanted to revise my MBBS days. So vaccination is the act of getting a vaccine to produce immunity. What's immunization? Isn't it the same? Well, immunization can be because of a vaccine, could be because of a natural infection. So these were, things and questions that were asked to confuse us and play around with us. And I think in YY, even now, people ask us this. With this background, immunization, you acquire either via a vaccine or an infection, and it is specific for a disease or specific for a strain. Whereas vaccination implies there's production of specific antibodies, memory in the immune systems, and it protects you from an infectious disease. Now coming to why vaccination, and Jugal sir has already elaborated on it, but I'll just speak in the context of respiratory medicine. Chronic respiratory diseases often have an altered lung defense. There are multiple comorbidities. These patients are often on immunosuppressants. Most of my patients are taking inhaled corticosteroids, which does slightly increase the risk of a pneumonia. Other than that, they are vulnerable to infections. They have frequent exacerbations. They have frequent hospitalizations. And this leads to disease progression. What this graph actually shows you is the natural history of the disease. What happens is there is one exacerbation and that leads to the subsequent one. And with every exacerbation, there's a sudden decline in the lung function and the risk of a subsequent exacerbation goes up. So what we are trying to do is, if we can prevent this first exacerbation, and this is where we're moving to. I have antibiotics, I have antivirals, I can treat everything. But my goal nowadays is prevent this first infection itself so that I can alter the natural course of the disease that is bound to happen in these patients if they are not vaccinated. So what do the guidelines say? It's quite simple. There's the Indian Geriatric Society, which talks of patients above the age of 50. They recommend pneumococcal vaccination in them. The gold guidelines are for COPD. They suggest annual influenza vaccine, COVID-19 vaccine, pneumococcal vaccine, RSV vaccine, Tdap if patient has not received it during adolescence, and zoster vaccine. GINA guidelines will also, GINA is for asthma. What have been looking for in asthma? They're suggesting an annual influenza vaccine. They are very ambivalent about pneumococcal vaccine. So in asthma patients, pneumococcal vaccine as a routine, possibly not needed. And COVID-19 was recommended even by GINA. Now, what are the available vaccines in India? Well, in pneumococcal, you have PCV10, PCV13, and 23. There are others which are available in the global market. In the in the research arena, you have trials on PCV20 also available. But as of now, PCV10, 13, and 23 are what are available to us clinically. Then influenza, you have multiple vaccine formulations which are available. So earlier we used to have what was a trivalent vaccine. Now we give a quadrivalent vaccine which covers the 2 of influenza A and 2 of influenza B. There is also a live attenuated influenza vaccine which is available. I'll come to this in detail. And then there is shingles vaccine, which is the new vaccine that has been launched in India by GSK. So which vaccines to be given? As I said, I'll be focusing on just 2 or 3 of these vaccines. One, the pneumococcal vaccine. So let's begin with what is pneumococcal pneumonia. Why are we so scared about it? Well, 10 to 30% of bacterial pneumonias are actually because of pneumococcus. That's a big number. Most common are LRTI pathogen, which is in all age groups. Now, when we look at chronic respiratory disease specifically, 7.7% fold higher incidence of pneumococcal pneumonia and 20-fold higher incidence of community-acquired pneumonia in COPD patients versus the general population. 19% of CAP now this was global data. Even if you look at the Indian data, 19% of CAP in Indian patients above the age of 12 years is actually because of pneumococcus, and 31% of community-acquired pneumonia in a tertiary care hospital in India. So it's a big problem. That's the only takeaway message from this slide. Now, how does it manifest? And what are we so worried about? If the patient has, a bit of sinusitis, bronchitis, to be very honest, I'm not that bothered. But what really scares me is once patient has pneumonias, and those pneumonias are invasive, and there is bacteremia. So what you would see is, all-cause pneumonias in the lung, 55% of them, as per this slide, are accounted for by pneumococcal. Some of them are invasive pneumococcal pneumonia, which means now it's in the bloodstream. That's a severe sepsis that I'm dealing with, high risk of mortality. Then there are other invasive pneumococcal disease such as bacteremia, meningitis, which may be without, a lung infection also. And then there are non-invasive forms, sinusitis, bronchitis, which, I'm not really that scared of actually. So what do I want to do? I want to actually prevent all the, severe pneumonias actually, but let's see how the vaccines have evolved. So we had PPSV23 from 1983. It's been there for a while. It's been used in children. In fact, there's a fundamental difference in how we've used vaccines in India versus what we use in the Western Hemisphere. In the Western Hemisphere, children used to get pneumococcal vaccine. I looked at my own vaccination card. As a child, I did not. So in India, pneumococcal vaccine up to a few decades ago was not a routine thing. Most of us probably have not received pneumococcal vaccine as a child. So this changes the perspective. In the West, they can give, just boosters and they are done with it. In India, most of us are unvaccinated when it comes to pneumococcal. So there are two vaccines which are available, broadly classified them, polysaccharide vaccine and a conjugate vaccine. Why I come to this is because their mechanism and their efficacy are slightly different. So what a polysaccharide vaccine does, it has a polysaccharide antigen which causes activation of the T cell. It is a T cell independent mechanism by which it generates an immune response. There is no reduction in nasopharyngeal carriage, no significant impact on the total pneumococcal disease burden because, its efficacy is, the immunogenicity is different. It reduces invasive pneumococcal disease. So when you have patients of severe pneumonia and bacteremia, it will reduce that. But when we talk of non-bacteremic pneumonia, it is not reducing it. So pneumonias can still occur if you have received a polysaccharide vaccine. Now let's come to a conjugate vaccine, the battle between polysaccharide versus conjugate. Conjugate there is a carrier protein to it, which increases the immunogenicity to it, which causes T cell dependent activation as well as causes the memory cells that are really important. After 4 years, 5 years, the vaccine is still active, it's still working. It reduces the nasopharyngeal carriage, which means there is a possible herd effect. It is associated with replacement strains, which means we used to have pneumococcus PCV7. So those 7 strains, pneumococcus has almost 90 strains. So those 7 strains actually came down and the others became important. So now we are actually expanding the spectrum. We've got PCV7, then it was PCV10, PCV13, PCV15, PCV20. In the global scenario, all these are available. In India, we just have PCV13 and 10 available. And it does decrease the pneumococcal burden. Not just invasive pneumococcal disease, but even non-bacteremic pneumococcus is reduced when you use a conjugate vaccine. So let's look at the evidence. PPSV23, this is the polysaccharide vaccine. It reduces the risk of invasive pneumococcal disease, effective against all-cause pneumonia. I don't know how much stats you guys see, but odds ratio is a very good way of representing stats. So, when it says the odds ratio is 0.26, it actually means there's a 74% reduction. Effective against all-cause pneumonia, odd ratio of 72, that means there's almost 28% reduction. And when we look at all-cause mortality, it's 90%, but the confidence intervals are crossing 1, which means it's not that significant. So that's the reason being it does not, non-bacteremic pneumonias are not really working well with PPSV23. This was a meta-analysis which was published in the Cochrane Library. Now let's look at conjugate vaccines. Why are we so fond of this? From my discussion, it may seem as if I'm more favored to a conjugate vaccine than to a pneumococcal vaccine. I'll come to that. For polysaccharide vaccine, I'll come to this. So, Capita trial was published in the New England Journal of Medicine. Big trial, more than 84,000 patients were given this vaccine PCV13, and they compared it to a placebo. This I'm not really happy about. They compared it to a placebo, and what did they find? So, when you look at the per protocol analysis, the incidence, the reduction in vaccine type community-acquired pneumonia, non-bacteremic pneumonias came down, and the vaccine type invasive pneumococcal disease came down. So it persists, and this is, mind you, a 4-year trial, which showed that these vaccines are working very well. Limitation was the excluded subjects who were regarded as immunocompromised. And for me, the biggest limitation is actually the third point. There was no comparative group. So once you're going head on to a vaccine, I actually wanted the two vaccines to fight it out and tell me which is good. So there is studies which have compared the two, and I'll ask you to focus on the right side of the panel. Look at the first year. Total rate of pneumonia significantly reduced in both of them. But let's look at year 2. The clinical effectiveness of the polysaccharide, the pneumococcal PPV23 group decreased as compared to the conjugated vaccine. After 5 years, you look at the pneumonia, the COPD exacerbations, actually the conjugate vaccine is doing well, not doing that well. So now comes the dilemma. Which one do I go for? There are, as I said, in India, we are thankfully not spoiled for choice. We just have two to worry about. Do I give 23 or do I give pneumococcal PCV 13? Now, what has been seen is, one, immunogenicity is better, but the spectrum is low. And because the spectrum is low and there are others which are now increasing, we have PPSV 23. So what we do and what I practice is I give the benefit of both the vaccines. While it's not one versus the other, why not give the combination of both the vaccines? And that's been a big game changer. So if you look at the guidelines, this is from up to date. You look at so most of our population, like look at all of us. How many of us have received PCV 7 or as a child or PCV 23 as a child? None of us. So basically, if you're healthy, not vaccinated, but if the patient has a chronic condition, as per guidelines, they're suggesting give PCV 20. But since that is not available in our country, what we do is we give PPSV 23 1 year after the last dose of PCV 10 or 13. And the same is for the age group of more than 65. Since most of our population is not vaccinated, we do this. Now, coming to what do the Indian guidelines say, and they are slightly different. The reason being, as I said, most of us have not received this vaccine as a child. The Indian Consensus Statements of 2019, which was published in Lung India, said that pneumococcal vaccine is usually not recommended for healthy adults under the age of 65, but immunocompetent patients with chronic disease, and this includes just everything. These chronic diseases are just, if you look at the OPD practice, this is more than 50% of the population. And patients who have a cochlear implant, who have had splenectomy, probably they obviously require these vaccines on a regular basis. Now, if once the age is more than 65, we suggest that we give PCV 13 followed by PCV 23, keep a gap of more than 8 weeks between the two vaccines. Changing gears, I'm now coming to influenza vaccine. This also, it's a influenza vaccine preventable disease. All of us, let's be very honest, all of us had an influenza. Last year, most of us had it, and probably all of us. What are we so scared about? What we're scared about is ARDS. You're not scared of a small flu that you're having. That flu is going to get corrected in no time. 7 days of taking antibiotics, not taking antibiotics, 7 days, and you're going to be fine. What really scares me is once you see young patients dying of acute respiratory distress syndrome, and this is from a register, these are all ARDS survivors. All of them had influenza, almost died of influenza. So this is what you need to understand. Influenza is not the standard flu that we're thinking about. We're thinking of a life-threatening disorder which kills. So influenza has, hemagglutinin and neuraminidase, and based on this, we've all studied about antigenic shifts and drifts. What scares you is a major change, the shift that occurs. And if you look at the, COVID pandemic, we all remember, but just go back a century old, we've had multiple pandemics of influenza, which has killed more patients possibly than COVID itself. You had the Spanish flu, then the Asian flu, the Hong Kong flu, and every time you'll find there's a big change in the antigens, which causes us to be, completely, we have never been exposed to this virus, and it wreaks havoc with our systems. Influenza is quite common, there's no denying it. I'm not worried about flu symptoms, the sore throat that we are having, but I'm worried about my COPD patients start having exacerbations. I'm worried once young patients start dying of ARDS. Influenza hospitalization is something which really scares you. Now, there are multiple vaccines which are available, the live attenuated ones, the inactivated ones, and the recombinant ones. All of them have to be given annually. One thing about the nasal spray vaccine, it sounds like a very convenient thing, and as Sir said, people will always complain injections are painful. But what is really convenient about this vaccine is it's a nasal spray. It's very convenient to deliver. But if the patient has, if the patient is living with an immunocompromised person, and come to think of it, we all, have elderly people in our household. I cannot take that vaccine because my mom's quite old. I mean, I don't want her to be exposed to it. The other thing is, if you have a transplant patient or a person who's on steroids at your house, you cannot take this vaccine. Then again, if the patient has taken any antiviral recently, they are not supposed to take this vaccine. But having said this, if you're going into a school and if you want to vaccinate many people, just put this vaccine into everybody's nostrils and they'll be sneezing around and it will be spreading around like anything. So that's one of the good ways of getting herd immunity. Now, there is a lot of evidence it has shown to reduce the number of exacerbations, hospitalizations, OPD visits, decrease all-cause and respiratory mortality. Even in asthma, actually, there has been meta-analysis which has shown that the vaccine is highly efficacious. Now, I come to what I bring forth. What is the practical problem that we face once we are, dealing with this? So, the Advisory Council on Immunization Practice recommends annual influenza vaccines for everyone. Single dose to be given annually. So there are two things. There's the Northern Hemisphere vaccine and the Southern Hemisphere vaccine. The Northern Hemisphere, where, winters or where you have a peak of influenza, it's given somewhere around October. And in Southern Hemisphere, in Australia, they're having a winter right now. They give the vaccine in April. Now, I'll just come to what is the India-specific problem in this. So there's a global influenza program which gives all recommendations on this, and if you go through it, it gives you a recommendation for all the years, and every year it's doing surveillance and trying to tell you which vaccine works for which time. But in February 2024, they've actually come up with just about a few months ago, they've come up for what would be the Northern Hemisphere vaccine for this year, and this is based on all the surveillance data that they've accumulated. And they give us these, till now they were giving a recommendation of quadrivalent vaccines. This time they said actually trivalent is as good. The Yamagata strain of influenza B is not circulating that much. But for influenza A, there's the Victoria and the Thailand strain. And for influenza B, there is the Austria strain for which the vaccines have to be developed. Now the problem, India-specific problem that I was talking about, we are a tropical country. And there's this very good editorial which was written, The Tale of Two Cities. It's inspired by Charles Dickens' book, but nothing to do with the book. It's talking about the two cities of Srinagar and New Delhi. And they compared the two. And what they found was Srinagar has a peak and Delhi has a peak. Very fundamentally different. There's Srinagar is having a peak from January to March. So there, giving a vaccine in October sounds like a very logical, reasonable thing to do. But New Delhi is having a peak during the monsoons. All of you must have experienced it. During monsoon seasons, you all develop a sore throat. So for us, possibly in Delhi, we should give the vaccine somewhere around April. Now, this is again a controversy. Where do we go? I mean, Delhi, will we look at regional prevalence for everything? We can't, to be very practical. How do I practically deal with it is I ask my patients, when did you have an exacerbation? If my COPD patient had an exacerbation during winter, I vaccinate him during October. If my COPD patient had an exacerbation during, say, around, the monsoons, I prefer the Southern Hemisphere vaccine. Living in Northern Hemisphere, we can still give the Southern Hemisphere vaccine. And if your patient's having too many exacerbations, actually, some guidelines are now even on the verge of recommending 2 vaccines to these patients. So, from the Indian perspective, ideally everybody should get it. That's my personal view. But again, we have to, we have a population of 1.3 billion. How will you get that much vaccine? So, we focus on age more than 50, pregnant females, chronic diseases, patients with conditions increasing the risk of aspiration, and healthcare personnel. And I was just sharing my experience with Joseph that, for my department, what I do is I indent the vaccine for every person. Every October, we indent the vaccine and we give it to all our patients. And then I got to know Sir is already doing it for the whole of the hospital. So thank you for that. COVID vaccine, I won't spend too much time on it. There's a lot of controversy, so I'm trying to sidestep it mostly. The vaccine is available. Again, with COVID, you're not scared of a small sore throat. You're scared of the patients dying of severe COVID. And we've seen that happen, right? So in asthma and COPD, patients with COPD have a 4-time higher risk of severe disease. When you look at patients with chronic lung disease, there's an increased risk of hospitalization, increased risk of death. There's lots of vaccines available. And, there's a scientific rationale of designing and the process of designing these vaccines. And a lot of technology, it's not the old, like Covaxin, yes, was a very conventional way of designing a vaccine. But there's a lot of interesting ways in which how these vaccines have been developed. And I'm not going to get into all of that for the time being, but the AstraZeneca has withdrawn its vaccine, but rest of them are available. Globally, in India, we do have Covaxin still available. Now coming to the last vaccine, and in the interest of time, I will skip most of the other ones. So shingles is, it's a reactivation of the chickenpox virus. Big deal. There are a few rash which will come, they will go away. Big deal. What we're really worried about is the post-herpetic neuralgia and the pain that the patient is going to live with for the rest of his life. So with that, they have come up with the shingles vaccine. It comes in a pack in which there are 2 such vials. They have to be mixed and given. They have to be given 2 to 6 months apart. Causes sore arm. Big. I'm not really scared of it. There's still a possibility of GBS also with this. So there, the side effect profile varies from one that will scare you and one that should not scare you. I'm not worried about sore arm and moderate pain, but I am worried if the patient develops GBS. That being said, it's contraindicated in patients who currently have shingles and in pregnancy. In the coming days, there's a lot of research in vaccine. You will have vaccines for RSV, Pseudomonas, Haemophilus, TB. So there is already trials on RSV vaccines which are ongoing. Pseudomonas vaccine, in cystic fibrosis, Pseudomonas colonization, if you can have a vaccine for it, it's a game changer. Haemophilus influenza vaccine, again, the evidence is coming up. Moraxella catarrhina, the evidence is actually emerging, but it seems like a very logical thing to do. So with my summary, in bronchial asthma, COVID vaccine for all, influenza vaccine for moderate to severe asthma cases, done routinely. In COPD, it's COVID, pneumococcal, shingles, RSV, Tdap. For ILD, for ILD, bronchiectasis and other chronic respiratory diseases, the evidence is still emerging, but we would like to, they also have a natural history very similar to COPD. So every time you have an exacerbation, they start deteriorating. So we want to prevent that exacerbation, and here also, I would recommend COVID, pneumococcal and influenza vaccine. And with that, I conclude. Thank you very much.
For the next session, may I please invite upon Dr. Rajesh Kumar sir. He is Professor, Department of Nephrology and Renal Transplant Medicine, VMMC and Safdarjung Hospital. Sir has done MBBS, MD and DM in nephrology. His areas of interest include clinical nephrology, renal transplant, intervention nephrology, CKD prevention and dialysis. So we'll be talking upon vaccines for liver and diabetes.
Thank you very much. Good morning, everyone. Thank you very much, sir, for giving me this very important topic and organizing such a nice CME, vaccination in adult. And good morning to all dignitaries present, speakers listening online. So my topic of presentation is vaccination in CKD and transplant. The overview of my presentation will be on the introduction, vaccination response in CKD, guidelines of the vaccination guidelines in CKD and adults. I will discuss on some individual vaccines which are very important in CKD and few ongoing research vaccines along with my summaries. CKD as such is a huge disease burden in our country, and almost 16% of Indian population are having CKD, and in 2023 it has been noticed that approx 2 lakhs of the new CKD patients are registered from majority of the tertiary care centers. We are maintaining their CKD registries. CKD is contributing to 30 to 36% of the death among the patients on dialysis, and infection is the second most common cause of death in CKD patients after cardiovascular deaths. As we know that vaccination induces cellular and humoral immunity. After vaccination, cellular and humoral immunity emerges and it protects us from the life-threatening diseases. Because CKD patients come to hospital and get repeated hospitalization due to infections of multiple episodes like chest infections, hepatitis B, which is most common in dialysis patient get hepatitis, flu, which leads further progress to the ARDS, as Dr. Rohit has already been explained. So current guidelines recommend immunization of all CKD patients regardless of the disease stage. It may be late, but it is never too late. So do vaccination in all the CKD patients regardless of the disease stage. And one very important thing is that live attenuated vaccines. We have 2 types of vaccines, live and killed. Live vaccines should not be administered in kidney transplant patients. there are immune alteration in renal dysfunction that causes decrease in efficacy of the vaccination. The various risks are uremia as such, oxidative stress, chronic inflammation, vitamin D deficiency, dialysis membrane bioincompatibility as a patient on hemodialysis, altered intestinal permeability, chronic inflammatory state, and immunosuppressive therapy in kidney transplant patients. These all factors causes inflammation. Inflammation is a process which affects each other in either ways. There is premature aging of the T cell, antigen presenting cells, B cells, which causes inflammation, and inflammation further causes premature aging of the immune system. So there are the alteration and monocytes become hyporeactive. There is decreased bactericidal ability of neutrophil. Cytokine levels are increased due to decreased renal clearance and production of the cytokine due to repeated infection and contact of the blood to the bioincompatible dialysis membrane, the patient who is on dialysis. And there is abnormal activation of the complement. As the general guideline for vaccine has already been discussed by Sir and Dr. Rohit, all healthy adults should receive DPT, polio, MMR, influenza, pneumococcal, HPV and zoster. And some risk categories has been defined for the vaccinations. Among these lists, CKD patients also come on second number, and other are diabetes, COPD, HIV, splenectomide patients, and patients on immunosuppressive therapy, cancers, and etc. So, vaccine recommended in high-risk individuals are hepatitis B, A, meningococcal, varicella, Hib, typhoid, cholera, and Japanese encephalitis in some selected regions where it is endemic. The common vaccination in CKD patients, what we advise in our CKD patients in OPD or indoor patients on discharge are hepatitis B and preferably recombinant pneumococcal, both PCV13 and PPV23, influenza, and other vaccines may be administered and advised in few cases like varicella vaccines, hepatitis A, tetanus, and toxoid. So, general guideline for the vaccination in CKD, if we are vaccinating CKD patients, there should be mandatory minimum waiting period for 2 weeks after giving immunosuppression. Then patient should go for the transplant if patient is under workup for renal transplant and waiting for transplant. Live attenuated vaccines have high risk of unchecked vaccine strain proliferation. So that causes vaccine induced disease in the transplant patient. So as I already explained in my first slide, post transplant all live vaccines are contraindicated. Vaccination with the we vaccinate the patients with the killed vaccines, and it may be commenced 6 months after post transplant, and before transplant we can give at any time. Vaccination of household contacts. As Dr. Rohit has already been explained, if I am going to take some vaccine, I will not take this because my mother is old or my father is old and he will acquire from disease from my vaccine setting. So, vaccination of household contacts in CKD patients and transplant patient is also important. In general, we also discourage inactivated vaccines in household contacts, and hepatitis B, pneumococcal, influenza vaccines are preferable vaccine in household contacts of the CKD patients and transplants. Administration of live vaccines we limit, and if patient have to take live vaccines, we ask them, please don't come in contact with the transplanted patient for at least 2-week period when viral shedding is highest during initial 2 weeks of the administration of live vaccine. First important vaccination is hepatitis B vaccine. KDIGO recommends hepatitis B vaccination for all CKD patients, and even we can vaccinate post-transplant because it is recombinant vaccine. We have two most commonly used vaccines, plasma derived and recombinant. Recombinant vaccine is preferred, and as CKD patients vaccinate, they should be vaccinated in earlier stage for the better seroconversion, as I already explained, with the progression of the disease, there is more inflammation and then more premature aging of the immune components and increased inflammatory markers that will decrease the immune response to the vaccinations. Other than the normal vaccine schedule, in CKD patients, we prefer double dose and 4 doses, and it gives seroconversion rate of 80 to 85% as compared to the 45 to 65% in the conventional 3-dose schedule. So we ask पेशेंट को स्पेसिफिकली हम बताते हैं, देखो तुम जाना, तुम्हें 3-4 बार इंजेक्शन लेना है. कोविड अभी जैसे था, हर किसी को शेड्यूल पता है. एडल्ट अक्सर हाँ भूल जाते हैं या जनरल पब्लिक को नहीं पता, तो हम उन्हें एक्सप्लेन करते हैं उनके लैंग्वेज में कि देखो तुम्हें 4 दफे इंजेक्शन लेना है, 1 ml इस बाह में लेना है, 1 ml इस बाह में लेना है. ताकि कई बार होता क्या है कि जब वो जाते हैं अपने लोकल प्लेस पे या कहीं जहां भी इंजेक्शन वगैरह लगता है, तो वो कहते नहीं एक तो काफी है, 1 से हो जाएगा, 2 लेने की क्या जरूरत है, हो सकता है डॉक्टर साहब ने आपको गलत एडवाइस दे दिया हो. बट इसको हम लोग इस पेशेंट को कि आप ध्यान से 1 ml इसमें, 1 ml इसमें, 1 ml contains 20 microgram unit of Hep B vaccine. So total 40 microgram of vaccination per dose, and 0, 1, 2 and 6 at 6 months we give. So at 2nd month it is the extra scheduled dose. After vaccination, we look for the seroconversion. So after completing the schedule, after 8 weeks, we check anti-HBs antibody titer. It must be more than 10 international unit per liter. And for better and better adequacy, it should be more than 100 international unit per liter. If titer falls or not rise, then we again give a booster shot of hepatitis B vaccination and again recheck anti-HBs antibody titer after 8 weeks of the booster dose. And if seroconversion achieved, then we check every year annual anti-HBs antibody titer, and it must be more than 10 international unit per liter on every checking. If patient does not achieve seroconversion, then some adjuvants are used in vaccinations like zinc, erythropoietin, and some immunomodulators like interferon and GM-CSF, granulocyte monocyte colony stimulating factor, for increase its efficacy. Various studies in hepatitis B vaccinations in ESRD patients has been seen, and it has been concluded and found that vaccinate before they start dialysis in order to improve the response rate, and elderly patients seem to have a lower rate of seroconversions after vaccination. Second common vaccination is pneumococcal vaccine. Severe pneumococcal infection is also one of the very challenging tasks in CKD patients, and patient got admitted with chest infections multiple times and remain admitted for 7 to 10 days each time, and they have to receive various broad spectrum antibiotic, and as such it increases hospital stay, use of costly medicines, economic burden on the family, and health infrastructure as well. So dialysis patients have a high incidence of respiratory infection with mortality up to 16-fold as compared to the general population. And as Dr. Rohit has already been explained, there are 2 types of vaccines, 13 and 23. We prefer combination of the both, and we ask patients, patient को हम ये बताते हैं कि पहले तुम 13 नंबर वाले टीका को लगाना, उसके 8 हफ्ते के बाद 23 नंबर वाले टीके को लगाना है, और ये दो डोज है. उसके बाद हर 5 साल पे 23 नंबर वाले शेड्यूल को फिर आपको बूस्टर करना है. But what happened from medicine OPD or any other hospital secondary level, only PPS V23 has been administered at various level. In that case, Advisory Committee on Immunization Practice Guideline recommend you must not miss the PCV13 vaccine. You give PCV13 one shot, single dose, 1 year after if patient has received PPS V23 dose. Difference has already been described, and CAPITA study it has already been discussed. Influenza vaccine. Influenza vaccine is indicated in all adults more than 50 years of age and in CKD patients at any age, irrespective of the stage of the disease or transplantation. Influenza vaccine should be given before the onset of spring season. We ask patient कि तुम मई से अक्टूबर के बीच में ले लो. इंडिया में जो मानसून सीजन स्प्रिंग सीजन है नवंबर टू फरवरी है. So we ask patient to take at least 2 weeks before the onset of spring season, and it is between May and June. And during, I think, June and July, every year new batch of influenza vaccine comes in market. So new batch to be taken during the month of July and August before onset of year. After kidney transplantation, routine annual inactivated influenza vaccine administration is recommended in all patients, and household contact should also receive these vaccines every year. Live attenuated vaccine of influenza is also available, but it should not be prescribed to the transplanted patient. Other vaccines are HIB, Haemophilus influenza vaccine. This is bacteria. A single 0.5 ml dose of HIB should be given intramuscularly, and to those patients who are susceptible to the Haemophilus influenza pneumonia. And HIB antibody titer should be checked after 4 weeks for the vaccination response. HIB vaccination is mainly prescribed in the patient who are splenectomized or patient who are going to get ABO incompatible transplantation. क्योंकि एबियो इनकम्पेटेबल ट्रांसप्लांटेशन में पेशेंट डिसेंसिटाइजेशन प्रोटोकॉल से गुजरता है. नेचुरल ट्रांसप्लांट में इम्यूनोसप्रेशन के अलग मोडालिटीज हैं. ब्रीफली बस एक ये मैं बता दूं आपको, एबियो इनकम्पेटेबल में पेशेंट्स 2 वीक बिफोर ही उसका ट्रीटमेंट शुरू हो जाता है, जिसमें रिटुक्सीमैब और प्लाज्माफेरेसिस की जाती है, which further decreases immunity, antibody titer in the body. So patients are prone to these infections. So patient must be vaccinated before initiation of the desensitization protocol, or if any CKD patient is going to be splenectomized. Diphtheria and tetanus has already been discussed, nothing different from the COPD. Herpes zoster is also nothing different from from CAPD. Only live vaccine should be contraindicated in transplanted patient. We advise recombinant vaccine, Shingrix, and 2 doses should be given at 2 months apart. Polio vaccine, as it is topic, today's topic is on adult vaccination, but I am discussing polio vaccine because patients also get kidney transplantation. So all the pediatric patients below the age of 5 years who are waiting for the transplant or transplanted, they should not participate in the National Pulse Polio campaign, and their household contact should also not get with their brother or sister. They should also not get oral polio vaccine, because there is chance of vaccine induced poliomyelitis to the patient as well due to the viral settings also. So injectable polio vaccine as per the universal immunization schedule should be administered to the patient and their household contact. Hepatitis A vaccination is the same, is nothing different than the normal population. We only check the geometric mean titer after hepatitis A vaccination, and it has been found that vaccination, if administered subcutaneously, it has greater geometric mean titer than the patient who had received IM. Meningococcal vaccine, also it is preferable in the pediatric patient, but if patients are planning for the ABO incompatible transplant or splenectomy, then meningococcal vaccine should be administered to those patients, and preferably quadrivalent vaccines to be given in that patients. MMR scheduled to be same. HPV vaccination, it is very important because immunocompromised hosts are at increased risk of cervical, vulval and anal carcinoma. So all unvaccinated male and female kidney transplant recipient between the age of 9 to 26 years of age must receive HPV vaccination, and HPV vaccination schedule is same as of the general population. And one important thing, if the vaccination has initiated pre-transplant, it could not be and not been completed, additional dose should be administered after 3 months of kidney transplantation when the intensity of immunosuppression is less. Typhoid vaccines available in 2 forms, live and killed. Schedule is same. Oral is alternate day 3 dose, and killed is single shot and repeat every 3 years. Typhoid vaccine is recommended. killed typhoid vaccine VI polysaccharide is recommended for the transplant recipient living in endemic area. Rabies vaccine post-exposure prophylaxis is same as of the general population. In transplanted patient or patient at high risk like CKD patients who are belonging to the high risk group like veterinary doctors or staff and any personnel working with the rabies virus, scientists, medical, paramedical, personal training rabies patients, dog catchers, forest staff and zookeeper, and in that cases pre-exposure 3 doses to be given 0, 7 and 28, and antibody titer to be checked after 6 months of administration of the vaccine, and it should not be below 0.5 international unit per ml. But we advise immunocompromised patient not to leave the place or job which comes under the high risk group. COVID vaccination, it is same, nothing different. Only one important thing is that mRNA vaccine is preferred in transplanted patient. If patient has already got infected in COVID, so 1 dose of mRNA vaccine at least 2 months after COVID-19 infection to be given. And if patient has not been vaccinated, then 2 doses of mRNA vaccine at least 3 months after transplantation to be given. And after that, anti-spike IgG BAU binding antibody unit to be checked, and it must be more than 264. If it target has not been achieved, then the booster dose to be given in these patients. CMV vaccine is under trial. Till now, there is no any significant difference has been found between CMV vaccinated patient and general placebo. So at present, they are not currently recommended in CKD patient and transplant. EBVAR virus is one of the most common infection found in post-transplant patient, which causes post-transplant lymphoproliferative disorder. In this EBV vaccine is under research and phase 2 trial, and hope it will have very good result, and other vaccines also under the clinical trial. So vaccination in ESRD patients, to conclude, are the hepatitis B, influenza, varicella, pneumococcus, and in solid organ transplant patients, inactivated vaccines like pneumovaccine, influenza, hepatitis B, hepatitis A, meningococcus, Hib, papilloma, tetanus, and recombinant zoster. Live attenuated vaccines, all the live attenuated vaccines are contraindicated in renal transplant patient. So on conclusion, immunization strategies should be formulated early in the course of progressive renal disease to maximize the likelihood of vaccine-induced immunity, as secondary antibody response are less affected by the immune compromised host. Avoid vaccination in the first 6 months following kidney transplant, as patients are on the maximum dose of immunosuppression. After 6 months, dose are decreased, and vaccine response we may consider. To maximize the response, the vaccine, it is reasonable to give vaccine when the patient are receiving the amount of immunosuppressive medication at the lowest, and live attenuated vaccine are contraindicated in kidney transplant recipients. Thank you very much. Thank you.
Thank you so much, sir, for such an informative session, and especially making us pay attention to all the details. We're getting a lot of comments online also, how all these sessions have been very informative. Now, I would like to ask if anybody has any questions related to the past 2 or 3 sessions that have taken place. You can raise a hand and ask. If anybody online has any queries, you can put it in the chat box or in the WhatsApp group.
But we can prescribe if patients are living in endemic area and traveling to some zone which is routinely 3 vaccines we are prescribing: hepatitis B, pneumococcus, and influenza. Yes.
Anybody else has any other questions? May I please request Jugal Kishore sir to felicitate with a moment. may I please invite Dr. Y.C. Polwal, Sir, Professor and Head, Department of Medicine, VMMC and Safdarjung Hospital. Sir has an experience of teaching for over more than 20 years with various publications. Sir has done MBBS from Calcutta Medical College, West Bengal, and MD from GSVM Medical College, Kanpur. Sir would be giving a lecture on vaccines for liver and diabetes.
Good afternoon, everyone, and my dear friend and colleague, Dr. Jugal Kishore. And I'm really happy that I am here. And I must thank Indian Association of Epidemiologists and Sir Dr. Jugal Kishore, especially for inviting me for this important session. And for all postgraduates and for all even faculty members, this is a very, very important session because there has been a lot of changes in the vaccination programs in India and abroad also. So Dr. Rajesh has also eased my program, lecture also. So he has also said something about hepatitis B. But I would like to say a few things, what latest advancement has been done in regarding hepatitis B. So next. Which one? Okay. So all of you know that hepatitis B, it's a DNA virus, and it has three layers actually. It's a बड़ा नहीं होगा क्या? नहीं full हो जाएगा. नहीं full का सर. F5 होगा ना slide show. Slide show नहीं है. अच्छा. तो इसका वो नहीं है marker. नहीं सर. Marker नहीं है. So it has actually surface antigen, okay, core antigen, and it has a nucleocapsid core also. So it's an outer lipid envelope and an inner nucleocapsid core. Nucleocapsid core actually it contains viral DNA and a DNA polymerase. Actually, there are 8 types of genotypes till today. So what we are actually developing vaccine, it is vaccine against the for the vaccine from the surface antigen only, because the core antigen vaccine and the other vaccine we are not able to develop it. So so you know that hepatitis B, the geographical distribution in the global distribution, a few countries they have a very, very high incidences of hepatitis B, like African countries and even Gulf countries also they are having high, and India actually comes in the intermediate zone in the hepatitis B. The intermediate zone means 2 to 8% of the population we are having hepatitis B. So hepatitis B actually it is a really global problem. It's a real global problem because 254 million people they are living with chronic hepatitis B as in 2022, and this vaccine it has come almost 40 years back, and it is a 100% preventable disease. Still we are not able to control it. That is a very, very peculiar thing. 40-year-old vaccine we are not able to control hepatitis B because of the reasons that I will tell you. In 2022 hepatitis B resulted in around 11 lakhs death. 11 lakhs death mostly from cirrhosis and hepatocellular carcinoma. And it is 100% preventable by vaccines that are safe, available, and they are effective vaccines. So it spreads mainly from mother to child. Mother to child transmission is the main mode of transmission, and you know everybody knows there is no cure because the virus engulfs itself in the nucleocapsid core. So till now we cannot use cure word for hepatitis B. It can be controlled. It cannot be cured. And patients usually recover within 4 to 8 weeks. Suppose if you have somebody has acute hepatitis, because I just wanted to give you some glimpses of the basic pathophysiology of hepatitis B and the clinical features. Is 95% of the people they recover with hepatitis B without having any surface antigen. So nothing to be so panicked if you have contacted somebody from hepatitis B, because 90 to 90, because if you have good immunity, you can recover from hepatitis B and there will be no surface antigen. But 5%, maybe sometimes 5 to 10% of the people, they remain with HBsAg positives. Okay. So 5% who got hepatitis B as adult become carrier. So everybody knows how it is spread sexually. It's sexual partners, from blood, sexually transmitted diseases, men having sex with men, and prevalence of HIV in hepatitis B is around 1%. So everybody who is having a surface antigen positive must get HCV and HIV. So these three tests has to be done simultaneously, because all this mode of transmission is the same. And prevalence of HPV infection in HIV is around 7.4%. This is a very peculiar situation. As of 22, we have so much facility of check HBsAg every nook and corner. Still only 13% of the people, this is a global estimate, they are aware that they are having infection, and only 3% they are on treatment. Just imagine, people have 20 years, 25 years, 30 years of surface antigen positivity, they do not know whether they are having surface antigen positive or not, because they don't get a routine surface antigen testing. Only when they develop cirrhosis or hepatocellular carcinoma, then they could know that surface antigen is positive. And according to the latest WHO estimate, proportion of children under 5 years of age chronically infected with HBV dropped to 1% in 19 to 5 from 5% in pre-vaccine era. So definitely vaccine is working, because just from 5% to 1% of the children still they are having chronic hepatitis. For World Hepatitis Day 2023, WHO focused on one life, one liver. So this is the WHO 2023 slogan. One life, one liver. For a healthy life and needs to scale up, we have also a national viral hepatitis control program, which was started in now 2018. And up to the target is up to 2020-30 you have to end hepatitis B, C, A, whatever it is, E even. So we have to not only control, we have to eradicate hepatitis overall by 2030. So this is a global program, and India has started National Viral Hepatitis Control Program on 28th of July. Why 28th of July? Because it was Bharuch Blumberg, who was working at Fox Chase Cancer Center, discovered Australia antigen in the serum of Australia Aborigine persons. So in 1968, this HBsAg was discovered actually. Just imagine how many years it has passed. And that causes, earlier it was called serum hepatitis, because they were thinking it's processed from the plasma. So by virologist Alfred Prince, and in 76 Blumberg won the Nobel Prize in medicine for his work on hepatitis B. So 28 July was the date when he discovered, that is the official figure. So first hepatitis B vaccine was approved in the United States in 1981, just 43 years back, first vaccine, and the program in India was launched in 2002, hepatitis B vaccination program. WHO recommends all infants should receive hepatitis B vaccine as soon as possible after birth, within 24 hours. So it's coming under the National Immunization Program. Protection lasts 20 years, 30 years, nothing to worry. If the patient's immunity is good, protection will last for 20 years or 30 years. There is nothing to worry. WHO does not recommend booster vaccination. So there is no confusion. Sometimes there is a lot of confusion is concerned. And Heplicib B is only improved for prevention hepatitis B in adults. Immunogenic. It has a S, pre-S and pre-S2 vaccine, and that recently received marketing authorization in the United States 21, European region and UK and even Canada, but it has not come to our country still. So this is just 22. So these are just a snapshot of the pre-Havrio, which is using actually mammalian Chinese hamster ovarian cell. So this is very important, that the important thing is that how much the vaccine is generating your immunogenicity. If the immunogenicity is 50-60%, or if the immunogenicity is 90%, more than 90%, then definitely that vaccine is more effective. Angerix B is available. I don't know about the Previo, and these latest vaccines, I think they are not available. Now, can we have a therapeutic vaccine? I do not know whether this concept has come recently, that you give vaccine and you cure hepatitis B. That is the latest thing which I have also learned, that by giving vaccination you cure a disease. So vaccine, we were thinking that it is for prevention, but now it has come for cure. So this is called actually Tharvac B vaccine, which is a first human clinical trial was initiated January 25th of January 24. Whereas prophylactic vaccines, they are working for the prevention of illness, but therapeutic vaccine stimulates such an immune response that they clear the virus. That is very, very important. This vaccine has already gone through extensive preclinical testing, having progressed through 12 years of basic research, and this vaccine is this vaccine is actually therapeutic approach to cure. This is a global achievement for the hepatitis B treatment, because if you can have a vaccine which can cure hepatitis B, then I don't know whether it should be called a vaccine or not. So results from the phase 1 study of Tharavac, they are expected to be made public by the end of 24. So it's a very initial stage, phase 1. So this is actually called functional cure of hepatitis B. Functional cure of hepatitis B associated a higher frequency of functional, because it stimulates actually CD4 memory T cell response. So if the CD4 memory T cell response, if it can stimulate, so it has the advantage of curing hepatitis. So immunotherapeutic approaches are designed to induce HBV functional cure should also aim to improve CD4 T cell responses. Then there is one more actually drug which is actually under clinical trial, that is called Bepirovirsen. Bepirovirsen is a drug which is being developed by GSK, and it also looking for a functional cure of hepatitis B. This is also a very big achievement by the scientists, that if a drug has come which can cause functional cure of hepatitis B, then it's a very promising result. It's under phase 2 trial, and they read out in June 2022. So now initiated a phase 3 trial, and the results will come at the end of 25. So it's an anti-sense oligonucleotide that targets hepatitis B messenger RNA that act to decrease levels of virus. So it's working at the genetic level. So I will not be complete if I don't talk about hepatitis A vaccine also. Just a few slides for hepatitis A vaccine. Ideally, we are having hepatitis A outbreak in so many parts of our country, and sometimes now hepatitis A outbreak is going on in Kerala. You must have heard that, read also, and there have been death also. So hepatitis A is not that innocuous disease. It like hepatitis E. Hepatitis A sometimes can lead to a very fatal course. So ideally should be given. All children should be given less than 1 year or less than 5 years. They should be given hepatitis A vaccine in the upper arm in 2 doses is the best protection, and the dose and the immunogenicity is quite good. Hepatitis A vaccine also. So and the initial dose of the vaccine should be followed by a booster 6 to 12 months later. Protection against hepatitis begins 2 to 4 weeks after. The combination vaccine actually contains hepatitis A and hepatitis B also. It is in the WHO list of essential medicine. Hepatitis A is effective in 95% of the cases, and it was first approved in Europe in 91 and the US in 95. So if we have so much of frequent outbreak of hepatitis, why can't we give hepatitis A vaccine to all our neonates and infants? That is very important. Hepatitis A vaccine, they recommend specific members of population who are considered. They say that by the time the child is up to the 5 or 10 years of age, he develops immunity to hepatitis A. So in India, they are telling the hepatitis A is so frequent, so rampant that no need to give hepatitis A vaccine. But this is a point which should be discussed, and it's a point of debate also. That hepatitis A vaccine are recommended for specific members of population who are considered higher risk of infection. They include children, people with medical risk factors, those with developmental disabilities, people with occupational lifestyle risk, and travelers to the region of high indemnity. So that is hepatitis A. The 2-dose series that I've already covered. Hepatitis A vaccine is recommended for pregnant people, pregnant person who are at risk of contracting hepatitis. So pregnant ladies, hepatitis A should ideally be given. It is safe in pregnancy also. And by 5 years of age, usually in India they develop immunity. But anyway, there is no specific vaccine for hepatitis C. Just I want to tell you that the good part of hepatitis C is that it is 95% of the patients, they are being cured. They are cured of hepatitis C. So nothing to worry if somebody has contracted hepatitis C. So it's a curative treatment is 95% effective, almost with 4 weeks of therapy only. So once the mother has given birth and completed breastfeeding, it is safe to begin treatment. So hepatitis C is not a point of concern because it is a curable disease. HCV vaccine, there is no HCV vaccine until because of the so many reasons. There are 7 genotypes, multiple subtypes, so they are not able to develop hepatitis C vaccine. 60 subtypes they have been identified, and there is still phase 1 clinical trial hepatitis C vaccination. So vaccines, not just this is off the track, but still I would like to tell you that vaccines which are not recommended during pregnancy, है ना? So human papilloma HPV vaccine, MMR vaccine, live attenuated live influenza vaccine, varicella vaccine, and certain travel vaccines like yellow fever, enteric, typhoid fever, and Japanese encephalitis. This is just to complete the this. So thank you very much. If somebody has any questions, I would definitely answer.
Anyone has any questions related to the topic, online or in person? Yes.
After 3 doses, the patient will not achieve the tricycle failure. So we have to give the 3 doses again or only one.
Ideally, you have to repeat 3 doses. Yes, because if there is no antibody titers less than 10, then you have to repeat the schedule.
That is IM or IIT?
No, IM. It can be given intradermal also.
Any other questions that we have? Thank you so much, sir, for delivering such an insightful and informative presentation on hepatitis A, B, and C. Your expertise and clear explanation have greatly enhanced our understanding of this critical subject. May I please request Shalini ma'am to felicitate sir with a memento. Thank you so much, sir. With this, we would like to move forward to our lunch. We'll join back at sharp 2 p.m. Lunch बाहर होगा, अंदर खाना अलाउड नहीं है. अच्छा, we'll distribute the lunch here only. Where is this your pen?
Humble request to everyone, after lunch, please discard the boxes outside in the dustbin. Humble request to all, please. Okay, एक नोटबुक सर को दे सकते हैं
HIV or immune compromised patient. So these are the broad classification. How this immune system altered or changed in the HIV patient. We all know HIV virus post-infection is affect the CD4 and CD8 count, but primarily it affect the CD4 count. Okay, normally the CD4 CD8 ratio is more than 1, but when it altered, it is less than 1. The patient become prone to develop the cancers, infections, viral infections, and the opportunistic infection. So, and these infections become more severe in future if patient is not taking ARTs or patient is not taking any treatment. So we can see after these taking ART, the immune system of patient improve, but it is not same as the healthy individuals, like healthy controls, because there is some alteration in the CD4 responsiveness of the vaccination. So it is important to follow up all the patient post vaccination. The response of vaccine is not same even patient is having a good CD4 CD count after starting the ARTs. So we have to follow the patient. Does patient develop any complication related to the vaccination? So we have to keep this in our mind. Okay. So when we have to give the vaccination and why we have to give the vaccination? Because these HIV patients are prone to develop the many vaccination preventable diseases. So when patient is having, this HIV patient is having CD4 count more than 200. So it is ideal to advise for the vaccine preventable and the future diseases, because the mortality and morbidity and the complication associated with the disease will be low, and his lifestyle will be much better in comparison to the patient who are not receiving any vaccination. Okay. And when we have to advise the vaccinations, so in case of HIV positive patient who is taking the ARTs, the CD4 count should be more than 200 and your RNA value should be less than 50. So these are the cut point for starting the vaccination in the HIV positive patient. But in case of malignancies, in case of patients who are immune compromised because of other diseases like CKD, like diabetes mellitus, like CLD. So in these type of patients, we should try to give the vaccine in the early phase of disease, because immunity or immune response is going to wane in the future course of the disease. Okay. And when there is when a patient has been receiving any chemotherapy, any radiotherapy, or any transplantation has been done, so it is advisable to avoid the vaccination within the 3 months of this procedure. It is better to give the vaccines after the 6 months. The immune response will be much better, much good when vaccines are giving timely according to this. Okay, so what are the detrimental factors for a good immune response after giving the vaccination? Or in case of HIV positive patient, it is always advisable the patient should be adherent to the ART. It should not happen that patient is taking ART on a irregular basis, or he is taking ART for 3 months and taking a break for 1 month. Okay, your immune response after giving this vaccine can go wrong. Even a vaccine associated disease can happen in these group of patients. Okay, your HIV RNA load should be less than 50 for a good immune response after giving these vaccines. Okay, and as I have already told you, your CD4 count should be more than 200 for a good immune response after giving the vaccines. But optimal response is when CD4 count is more than 500. Okay, and there should be no other any active infections or no any other co-infection in vaccines for this compromised patient or HIV patient. Okay, so always be experienced and talk to the experienced person who is giving vaccine for these subgroup of the patient. Know your patient. Each patient is adhered to the ART. What is the immune status? What is his recent recent CD4 count? What is his recent RNA level? So you should be aware about the patient also. Know the vaccine. you should be aware कि which type of vaccine we are giving. It is a kill type of vaccine, inactivated, live vaccine. It is a this toxoid vaccine. So you should be fully aware about the which type of vaccine you are going to give for this specific subgroup of patient. Okay. And another point is how to optimize the efficacy of your vaccine. This is also very important. How we can optimize? We can optimize the patient after checking the immune status of the patient or whom we are going to give the this vaccine. We can recheck the vaccine efficacy after some months, after 3 months, by doing the immunoglobulins level, by doing the CD4 count, by doing the CBC level. What is the is there any change, and by doing the antibodies. Okay, but routinely it is not advisable to do these because these are very costly investigations. We cannot do on this large scale, so we have to be very careful. What are the limitations or barrier for vaccination? In COVID time, we have seen there was a vaccine hesitancy, and we are not having a predefined program from our government organization or our medical fraternity also. None of the medical fraternity, even from the pediatrics, gynecology, or any physician fraternity, they are having any this guidelines for the immunization in HIV or immunocompromised patient. Okay, so because there is no defined data, no defined research, especially in our country, so there is vaccine hesitancy in this specific group. So we have to counsel the patient. Okay, what are the benefits? What are the merits? And we have to counsel about what could be the side effect. So patient gain the confidence in you while he or she is discussing about the vaccine. Okay, and you after giving the vaccination always keep a follow-up, because it is not normal as we are giving the vaccination in the normal adults. So sometime vaccine can go in the wrong way. So vaccine per se can cause some infections. Vaccine per se can cause some idiosyncratic reaction. So you have to always go for follow-up also for post giving these vaccinations. Which vaccines are safe in HIV and immune compromise? We all know the killed vaccines or non-live vaccines are considered to be safe in this group. But as I have already told you, the duration and magnitude of the immune response after giving these vaccines are not same as the healthy control in adults. There is always suboptimal response of vaccines in this specific group. So we have to be very careful after giving these vaccines. So live vaccines are totally not advisable. They are relatively contraindicated in the immune suppressed or HIV patient. These are the vaccines which are live vaccines: MMR, varicella, this live attenuated influenza vaccine, yellow fever vaccine, and in pediatric age group we have oral polio vaccine also. So these are the vaccines which are not advisable in immune suppressed or HIV adult patients. Okay. So these are the just comparison in a tabular form. These are the recommended on the left side, non-recommended on the right side. And in recommended, hepatitis A, hepatitis B, human papilloma virus, Hib vaccine, pneumococcal, TT, DPT, booster with precaution. Booster with precaution means your CD4 count in HIV infected patient should be more than 200. It is one of the prerequisites for giving this booster vaccination. COVID vaccine we have given in all type of patient and groups, and not recommended, you can see all are the live vaccines. These are the schedule. Schedule is more or less same in the adult, normal adult groups compromise. Only difference is we need to give the extra dose or higher dose or booster dose. Okay. Otherwise, it is schedule is the same in adult and the HIV and immune compromised patient. These are the adult vaccine which are recommended. Okay. So after giving the vaccination, how will you see your immune response is good, intermediate, or it is poor? Because we have to decide that we have to give the higher doses, we have to repeat the doses, we have to give a booster for some specific vaccines. So if immune response is 60% in comparison to the normal healthy volunteer, adult volunteers, it is considered to be the good immune response post vaccination. So these are the diseases or conditions where immune response is suggestive to be good, like in CKD, HIV infection when CD4 count is more than 200, other immune mediated diseases or solid tumors. Okay, in intermediate response, the immune seroconversion is 40 to 60% of all total in comparison to the adult healthy controls patients. Okay, and you can see in intermediate, the CD4 count is less than 200. So these are the differentiating point. In when poor response means when this seroconversion is less than 40% in comparison to your healthy adults, and CD4 group is less than 50. Okay, so these are the vaccine related seroconversion or immune response. So we can broadly categorize, because we have to decide which patient need extra doses, higher doses or booster doses in future. Okay, so when patient is having some intermediate type of response after giving the vaccination, or patient is having poor type of response, so what are the innovative steps we can do? What we should consider to increase the post vaccination immune response in our specific HIV negative, HIV positive and immune compromised patient? So we can invent or we can add the adjuvants. Adjuvants like we have alums, we have some peptides, okay, in hepatitis A or hepatitis B vaccines. Okay, alum, this adjuvant increase the immunity of the vaccines after adding this with the vaccine. We need to give the higher doses. In case of hepatitis B, we used to give the 40 microgram of this vaccine in comparison to 20 in the normal adult group. Okay, we have to give the extra doses. We have to give the booster doses also. Normally booster dose is required after 10 years in case of this hepatitis B, but in immune compromised or HIV patient, we need to go for this antibody titers after 5 years, and when they are less than 10, so we should consider for a booster dose. Okay, so by these innovative steps, we can increase the immune response of these our vaccines. Okay, and regularly we have to check the immune status in the selected cases. And now we are also saying, okay, now inactivated vaccines are also being developed in our country, like varicella zoster vaccine, cytomegalovirus. These are totally safe vaccines in the HIV positive patients or immune compromised patients. So these vaccines can be considered. Okay, so this is one of the important question. Do we have any vaccines against HIV? No, not yet. Okay, it is under process. So research is going on. Maybe in coming 1 year or 2 years, we can have the vaccination against this. So what are the key points? Okay, so key point is to see a good response after vaccination in HIV patient or immune compromised patient. Always know the immune status of your patient. Don't be in hurry to give the vaccine. Give some time. Get the routine investigation. Get the RNA levels. Get the CD4 count, CD4 and CD8 ratio in your patient. If you see these immune status is okay, so you should consider to the vaccine. Otherwise, these vaccine can cause the harm also. Okay, killed vaccines or inactivated vaccines are totally safe in these type of specific group. Live vaccines are having the challenges, so they are contraindicated. Immune response is lower or suboptimal. Even patient is on ART. Even patient is having the CD4 count more than 500. It is not same as the normal healthy adult patient. It is always suboptimal immune response after giving the vaccination in the HIV positive patient. So we have to keep a close follow-up. We have to do a routine this antibody titer in future, because patient may require the booster in future. Okay, and we have seen we are not having any data, we are not having any awareness program regarding the vaccination in immune compromised or HIV patient. So most of the population is under vaccinated. So we have to we have to increase the awareness among this specific group of patients. Okay, what are the benefits of getting the vaccination? How you can improve your life in after getting the vaccination. Okay, so and government should also focus on dedicated research in this specific group. Okay, and one more important point is household of this subgroup, HIV positive and immune compromised patient, should also be advised for the full vaccination as per our adult immunization schedule. Okay, by doing this, we can prevent the disease spread and recurrent infection to the HIV or immune compromised patient. Okay, so what are the way forward? So as I have already told you, we are having a very limited data and no research, no dedicated research from our country in this specific group. So we have to think about this, how we can improve, how we can approach the government, how can we request the government so they can dedicatedly start some program, some research work in this specific group, so more experience can be gained in this group. So after doing vaccination in this specific HIV positive and immune compromised patient, their future life, their lifestyle can be improved, their morbidity, mortality related to the vaccine preventable disease can be avoided. Okay, expert in the vaccination should be involved in all these vaccine coverage to increase the vaccine coverage in this specific population. We are not having yet what are our targets, how much percentage of these specific groups should be vaccinated. So we have to think about this also, and we have to innovate new approaches, we have to explore new things. Okay, how we can increase the immune response after vaccination in these specific subgroup. Okay, so these are the way forward we have to see. And thank you. Any question, any comment from the audience, sir? Please.
Anyone has any questions related?
Start the vaccine. Then the CD4 count is more than 200. And you also said when after starting ERT, suppose CD4 count is 50, then we should not see the
We want to see we should advise the vaccination in HIV patient when CD4 count is more than 200. But yes, in some subgroup of patient after starting the ART, CD4 count in most of the cases improved. But in some subgroup of patient, it can not also be improved. And the vaccine response in the HIV infected patient or HIV positive patient, even he or she is on the ART, is not same as the healthy adult patient. There is also suboptimal response of vaccines in HIV patient even after patient is on ART.
even if CD4 count increases from 50 to 200, and we can recommend it.
Yes. Okay, I have shown in one of my slide, immune response will be poor when CD4 count is less than 50. It will be intermediate when CD4 count is less than 200 or in between 50 to 200. And it will be good when CD4 count is more than 200. Okay, so this is the importance of knowing the immune status of CD4 count in a HIV patient who is receiving the ART.
Any other question? Anyone has any other question?
I kept two questions for you. I think we are.
Yes, sir.
It's coming. Yes. What is your question? I'll try to give your answer. If BCG is totally contraindicated in the HIV patient. BCG is absolutely contraindicated. It is not related to your CD4 count. HIV patient, it is not advisable. Any other question? Do we have a question?
Sir, those two questions I posed, we have put it in the pre and post test.
Okay.
We can still read it out.
So one question was, which vaccine is absolutely contraindicated? So she has already asked. BCG is the absolutely contraindicated in HIV positive patient. Okay. And second question was, which vaccine? What are the detrimenting factors for vaccine efficacy in HIV patients? So it is the RNA level. It should always be less than 50, and CD4 count. It should be less than more than 200. Okay. Any other question or comment? Thank you.
Anyone from joining us online has any other question? You can please put it on the group. We can take it after the next session. Thank you so much, sir, for such an enlightening presentation on this topic. Your expertise and detailed insight have significantly deepened our knowledge on this important vaccination topic. May I please invite Dr. Jugal Kishore, sir, to felicitate sir with a memento.
Actually, this book is written by our teacher. We both are actually a student of Dr. R.C. Jiloha. He is now retired psychiatrist. He was working in GB Pant Hospital, has written a biography in the name of a case of early life psychopathology. It's a wonderful book. So just I'm giving to him.
Thank you, sir, for giving this book. And Dr. Jiloha was teachers for the teachers. He was head of department at GB Pant Hospital for more than 2 decades. And he is having so vast experience of life along with the medical field. So he has tried to put his experience in this book. And I especially thank Dr. Jugal Kishore, sir, for giving this book. And I'll try to read this book in coming this one, because I am having other engagements also. So, thank you, sir.
Thank you, sir. For the next lecture, may I please invite Dr. Sneha, Assistant Professor, Department of Community Medicine, VMMC and Safdarjung Hospital. Ma'am has done MBBS, MD Gold Medal in Community Medicine, DGO Diploma Obs Gynae, DMB in Community Medicine and MBA. Ma'am has over 35 research publications in various national and international journals with various chapters in many famous books, and ma'am is a co-author of a famous public health book. Ma'am will be presenting a lecture on vaccine for healthcare personnels. Thank you.
Good afternoon, one and all. Today's most interesting and important topic, which is relevant to all of us, is the vaccination for healthcare professionals. as we all are related to healthcare system or are healthcare professionals. So what are the vaccines which are needed for us? So this is the presentation, and we would like to have an interactive session just to know that what are the vaccines which are applied for us. So proceeding forward, as we all have discussed from morning, Dr. Jugal Kishore sir has beautifully explained that why adult vaccination is needed. Just re-emphasizing the key features why adult vaccination is important. The main features are that it provides protection in the way that VPD can lead to serious health complications, hospitalizations, and even death, particularly in older adults or those with underlying health conditions. Because in old conditions, our immunity compromises, so we need protection at a higher level. Next is maintain herd immunity, as sir has already explained about that, how herd immunity can be attained by having adult immunization. It reduces transmission of fatal diseases and it maintains healthy workforce. That is, it plays a crucial role in maintaining a healthy workforce and preventing disease outbreaks in community setting. As we all have must heard or seen on the television that nowadays Delhi and NCR region are affected with having mumps outbreak. So why these outbreaks are happening? Just because our adult immunization rates are very low, so these outbreaks again affected time to time in adult population also. Now next, one important term that is crucial to know for undergraduate student and postgraduate student, because this audience gathering is of mixed gathering. We have undergraduate student, postgraduate student from other medical colleges of Delhi and NCR, and we have also audience from other states also. So there is one important term, that is immunosenescence. What does it mean? Immunosenescence is that as individual ages, their immune system may weaken, making them more susceptible. This results in preventable morbidity, and this can be prevented. So we are discussing about that. This results in preventable morbidity or mortality, excess hospitalization, diminished quality of life, medical complications, missed work period, economic loss. So this is the reason that why we are concerned about having adult immunization. Next important factor that is important for having adult immunization is that it promotes healthy aging. As we are advancing towards aging process, we have more population of aged population in our demographic system, so we are focused about having healthy aging. As life expectancy increases and healthcare becomes more accessible, the percentage of the population that is elderly also increases. It is estimated that 23% of the population are now elderly, and they are to be taken care of. And also due to our increased international travels, we have some infectious diseases which are in the stage of emerging and re-emerging diseases, that is affecting not only at the endemic level, epidemic level, but also on the pandemic level. So due to demographic shift, immunization campaigns are crucial for reducing the risks infectious pathogens pose to the public health. Now next question arises in our mind, why healthcare professionals need immunization? Why us? COVID-19 में भी हमें ही सबसे पहले किया गया immunize. Why? Because you should understand your dignity and respect. A country or whole globe needs you people. That's why healthcare professional immunization is very important. They are at risk category. You are dealing with patients, infectious conditions, so you people are at more risk, or we all are at more risk. Second, by setting an example. Because if healthcare professionals don't believe on medical evidences or scientific literatures or scientific researches, then why the common people believe on adult vaccination, believe on adult immunization? बच्चों के लिए vaccination है, हमारे adult के लिए कुछ नहीं है. We are all healthy. But as a healthcare professional, we need to understand the importance of adult immunization. Then why don't we create trend setting? We are trendsetter. When we will get ourselves get immunized, then layman person and general population will get immunization at the earliest, because they believe in you, they have trust in you. Third point is can promote others for immunization, because without doing, you cannot teach anyone. So you have to get immunized first, then you have to give advices, you have to convince other people for immunization. So next point is strengthening the healthcare system of country by protecting the healthcare professionals, because we have just crossed COVID pandemic times. And when we healthcare professionals are not healthy, how can we protect or prevent infectious diseases from our general population? So strengthening the healthcare system is must. Next point is protecting healthcare professionals from various infectious diseases are an important part of patient safety and infection prevention and control program in healthcare setting. So these are some of the important points that why we as a healthcare professionals need immunization. Now proceeding further. Now next question arises in our mind that which guidelines should we follow? Should we follow CDC guidelines? Should we follow IAP guidelines? किसकी guideline follow करें? IAP recommendations ये कहती है, CDC Atlanta की recommendation ये कहती है, हमारी IAPSM की guidelines कुछ और बोलती है. Then which guidelines to be followed? For this we have one recent guidelines, that is Indian Consensus Guideline on Adult Immunization, that have come in 2024. Indian Consensus Guideline on Adult Immunization developed by the API, Association of Physicians of India. This concerted initiative does not merely streamline vaccine distribution, administration and monitoring, but also amplifies India's potential to aptly deal with public health challenges, creating a platform for open communication and knowledge sharing between medical societies. Sari medical societies which are concerned with different age groups, different vulnerable population groups, different people at risk, they came together and come to a consensus that this guideline is to be followed. This endeavor marks a historic collaboration bringing together representatives from 13 diverse professional organizations. Now next question arises in our mind, which are these 13 professional bodies which have given recommendation on a common theme, that is adult immunization. This is IMA, Research Society for Study of Diabetes in India, Geriatric Society of India, Indian Society of Nephrology, Indian Society of Critical Care Medicine, Indian Chest Society, Indian Rheumatology Association, Heart Failure Association of India, Cardiological Society of India, Federation of Obs and Gynae Society of India, Clinical Infectious Disease Society, Indian Society of Oncology and IAPSM. All these medical societies have to sit together and have come to give on one common consensus that what adult immunization, what vaccines are to be included under this for different age groups, for different important and at-risk groups. But we will focus in this presentation only on the vaccination which are needed for healthcare professionals. Vaccine recommendation, which we will discuss further on, that can be stratified into 3 tiers. First is vital vaccines. Vital vaccines, what does this mean? That is critical for public health, targeting disease with high morbidity and mortality rates, emphasizing universal coverage to achieve herd immunity. Next one is that is like cost effectiveness. So this framework enables prioritization, optimizing resource allocation and informing public health policies for maximal impact on population health. Now this is the Indian Consensus Recommendation for Healthcare Professionals. as you can see that, as you have heard these vaccines from morning, different stations, different experts have given comments on these vaccines. These are some of the vaccines which are recommended by Indian consensus that should be taken for by healthcare professionals. Influenza, that is annually, frequency is annually, and that comes under desirable category. The Tdap, hepatitis B, MMR, and chickenpox are vital as per Indian consensus guidelines. And essential vaccines are typhoid and pneumococcal, and desirable is influenza. One by one, we will read about this vaccine, what are the key features and what are the points to remember at undergrad and postgrad level for adult immunization. Coming on Tdap. As you all know that it is diphtheria and tetanus toxoid and acellular pertussis antigens. It is Tdap, TD, diphtheria and tetanus toxoid. IM is root 0.5 ml. Every 10 yearly should be given, should be stored between 2 and 8 degrees Celsius. Contraindication, history of any allergic reaction. Points to remember. What are the points to be remembered? That is, in unvaccinated individual, 1 dose of Tdap, then 1 dose of TD or Tdap 4 weeks later, and a 3rd dose of TD or Tdap 6 to 12 months later. Tdap preferred as the first dose, with TD or Tdap every 10 years thereafter. Wound management, as you all know that in wound management we also give Tdap. More than 5 years for other wounds, prefer Tdap for those without previous Tdap history. Now this is the, actually I have also just put some photographs of some vaccines and what is the cost for these vaccines which you can purchase from the market. As you all are healthcare professionals, you can just write an indent for your department and the hospital can purchase on behalf of your department so that you can avail these vaccines. But the market rates, these are only estimates. These are only estimates for these vaccines, that how costly they are. They are not very much costly except pneumococcal vaccine, which is quite costly, which comes around 3,000 to 3,500. Rest all vaccines comes around 500,000 or some are even cheaper. We will come to know about that. Now next vaccine, that is hepatitis B. Hepatitis B, as we all know that it is recombinant DNA or plasma-derived inactivated subunit vaccine. I am in the deltoid region. We all have discussed about the diseases, about the manifestation. Just we are discussing about the key features of different types of vaccines. It should be stored between 2 and 8 degrees Celsius. Contraindications, any history of allergy. Points to know: at risk for hepatitis B virus infection, 3 doses is recommended, 0, 1, 6 months. Minimum interval between 2 doses is 4 weeks. Revaccination is recommended every 5 years for high risk individuals. Immunocompromised, as sir has said that, healthcare professionals CKD on hemodialysis. Travel in countries with high or intermediate endemic hepatitis A. Hepatitis A plus hepatitis B may be administered on an accelerated schedule of 3 doses, followed by a booster dose at 12 months. This costs around rupees 1,033 per dose. This is only sample just to have an estimate of what are the costing of different type of vaccines. Now comes influenza. Influenza that comes under inactivated influenza vaccine includes recombinant, trivalent and quadrivalent influenza vaccines. IM, live attenuated influenza vaccine are also available through intranasal route. Co-administration, as Dr. Rohit sir has beautifully explained about different routes of influenza, that co-administration, now we are doing co-administration as a way of vaccinating because we have opportunity to give different type of vaccines at the same time. So if 2 or more of the following live virus vaccines are to be given, then LAIV, MMR, VAR and or yellow fever, they should be given on the same day. If they are not given on the same day, space them at least 28 days apart. Now, what are the contraindications for live attenuated influenza vaccine? Age more than 50 years, pregnant woman, history of allergic reaction, received antiviral therapy, caregivers of immunocompromised patients, patients with asthma, GBS, and chronic conditions. These are approximate cost of different type of vaccines. The influenza vaccine that comes around rupees 20-24 per dose, and also on the nasal route that costs around 1590 per dose. Now next vaccine, that is measles, mumps and rubella. As we all know that it is live attenuated combined vaccine. The route of administration is subcutaneous. 0.5 ml, 2 doses, 4 weeks apart. Available combinations we have MR, MMR, MMRV. Precautions: moderate or severe acute illness with or without fever. If blood plasma and or immunoglobulin were given in past 11 months, wait for 3 months before vaccinating. History of thrombocytopenia or thrombocytopenic purpura. Points to note. Actually, MMR is part of routine in vaccination, but in today's times it was a part of routine vaccination because MMR has been replaced by MR. That's why this in the morning one question was raised by Dr. Karthik, that why we not introduce MMR again, because we are seeing outbreaks of mumps everywhere in the country. Because replacing IAP gives recommendation or on replacement of MMR with MR, IAP says that if we are vaccination against mumps, then why to stop that? Then Government of India has said that we have not sufficient data to declare it as a public health problem. So we are just replacing that. And second point, the Government of India has said that it is not so much cost effective. So it has been withdrawn. But we are seeing outbreaks of mumps all over the country nowadays. We have not published many published data, but we have many unreported data, unpublished data which reveal that mumps is the public health problem, can affect individual at any age group. And if it occurs in older population, then it affects more, severity is more. Then why we are having such vaccine, effective vaccine in the form of MMR, then why not introduce again in the national immunization schedule? Our department is under the supervision of Dr. Jugal Kishore sir. We are writing one paper and is recommending that MMR should be included under that. If coming to back on our slide, if unvaccinated, 2 doses at least 4 weeks apart. If woman of childbearing age is found to be rubella susceptible and is not pregnant, give one dose of MMR. If she is pregnant, the dose should be given postpartum. But the woman wants to conceive, then rubella vaccine cannot be given. This is the MMR vaccine approximate cost, that is 510 per dose, and MR vaccine that cost around rupees 75 per dose. Now coming on another vaccine, that is pneumococcal disease. We have different types, as we have discussed in detail in Dr. Rohit sir's presentation, that we have PPSV 23, PCV 13, PCV 15, PCV 20. Not going much of the details. Route of administration, as we all know that it is IM or SC. Intramuscular injection storage, we all know that. Co-administration, adults can receive pneumococcal vaccine, any PCV 13 or PPSV 23 with herpes zoster vaccine, seasonal influenza vaccine at the same time if required. So co-administration can be practiced. Points to note in pneumococcal vaccine, recommended for all, especially those with increased risk, irrespective of age. 1 dose of PCV 13 followed by PPSV 23 1 year later. Above 50 years, PCV 13 followed by PPSV 23 1 year later. At risk, PCV 13 followed by PPSV 23 1 year later. And a high risk, PCV 13 followed by PPSV 23 8 weeks up later. This is pregnant that approximate cost is rupees 3,000 per dose. It is the costliest vaccine which we are having. Next, all other vaccines are quite cheaper. Now next vaccine, that is typhoid. Typhoid, we have inactivated typhoid vaccine, typhoid conjugate vaccine, VI polysaccharide vaccine, live typhoid vaccine route orally. 1 capsule is taken every other day for a total of 4 capsules. Contraindications are pregnant women, history of allergic reaction to any expectations of the vaccine, and immunocompromised patients. Points to note, it should be given in professional food handlers, unvaccinated adults aged 18 through 45 years, travelers at risk of exposure during outbreaks. In pregnant females, always weigh the risk, the benefit versus risk before giving the vaccine. This approximate cost of this vaccine is conjugate vaccine is rupees 2,151 per dose. Now coming on another vaccine, that is chickenpox. That is comes in the form of live attenuated. Route of administration is IM. 2 doses 0.5 ml at least 4 to 8 weeks apart. Should be stored between 2 to 8 degrees Celsius. Points to note in chickenpox vaccine is only recommended in adults without evidence of immunity. Recommended in adults who are at potential risk of exposure, such as individuals or students residing in hostels, healthcare professionals, and household contacts. Post-exposure vaccination recommended within a few days to a few weeks of exposure. Incomplete vaccination 1 dose, not vaccinated 2 doses should be given. What is the cost of this vaccine? This vaccine costs around 1,281 per dose. Now the question comes that do we want to get adult immunization? As you have seen the cost, the feasibility, what are the needs of these adult immunization as a healthcare professionals. Just ask from your departments, ask from your institution that just raise the demand and get it soon, because if you people will create a trend, then only the general population will have herd immunity or will have convinced from your efforts. Thank you.
Anyone has any questions related to the lecture?
Yeah, first I would like to congratulate you. It was a very good presentation regarding the healthcare vaccinations. Okay. So your topic was healthcare vaccination actually, and when I was listening to your, sorry to say, it was looking like a vaccination in adults. So what are the must vaccines in healthcare workers? And second thing is, when we are giving a lecture in platform like this, we should never ever give the cost of any device. We are not here to give the cost. If we are working in some organization, this is the responsibility of organization to vaccinate us. Okay, so these are my comments. So what are the must vaccine for healthcare? This is my question. Must.
So as I have depicted in our slide also, vital vaccines which are must for. Vital vaccines as the Indian consensus guidelines has given that. Show me that slide. That comes that Tdap, MMR, chickenpox are vital vaccines which should be taken by healthcare professionals. As I have also highlighted in my slide that vital vaccine should be taken.
Sometimes the need based or time based also.
Yes, sir.
In year 2005 to 6, there was a epidemic of meningococcinia.
Yes, sir. Yes, sir.
Vaccine was given freely to all healthcare.
Yes, sir. Time and the situation just needs that what are the vital, sir, vital vaccine should be taken at the priority level.
Now, what is the recommendation for COVID-19? COVID-19.
Yes, sir. But that has already been discussed from morning, so I have not emphasized much on that. Okay, thank you, sir, for your time. Any other question or doubt if you people are having? Thank you so much for patiently listening.
Anyone attending online has any questions? Online, is there any question which is coming up? Anyone attending the CME online has any question? Thank you so much, ma'am, for a dynamic and insightful presentation, for addressing our common concerns. Your engaging delivery and expert knowledge have provided us valuable guidance for protecting ourselves and our patients at the same time. May I please request Jugal sir to extend, okay, so next time I will invite. Dr. Pratap and Dr. Jugal to please felicitate ma'am with a memento. Thank you so much, sir. Thank you, ma'am. For the next lecture, may I please invite Dr. Sarita Singh, ma'am, Specialist and Associate Professor, Department of Obs Gynae, VMMC and Sadarjung Hospital. Ma'am, okay. Ma'am will be presenting on vaccines in females and during pregnancy. Thank you.
Thank you for the kind introduction. Dr. Sneha has made my talk very simple. She's told everything in detail. I won't be telling much about adult vaccination. Actually, my topic was in females as well as in pregnancy and adolescence also. So female as male and female have similar requirement of vaccination, so that I won't go much in detail. I would go specific to pregnancy and HPV that I would cover. How to start? Yeah. Okay. Okay, so we have specific needs in pregnancy because we generally want that all women before becoming pregnant should be vaccinated thoroughly. But somehow what we generally get to see is we have a pregnant woman in the OPD, we first visit, we just take the history and find out a lot of vaccination have been missing because they haven't received most important vaccination, which according to us is MMR, because that causes congenital anomaly in the babies. So that is very important. Of course, the influenza vaccine and other vaccinations, like Dr. Sneha has told, they are also important. From a fetus point of view, we do consider MMR as one of the most important vaccinations before pregnancy. So, pregnancy should be ruled out prior to vaccination because we cannot give live vaccination in pregnancy. Why we can't give live vaccination in pregnancy? Anybody can answer? Because viral application happens. So we are not supposed to give because it will cause high load of viremia and infect the pregnant woman. And that can affect the fetus also. So as a general rule, we don't give live vaccines in pregnancy. Okay. This mouse is not working. Okay. So as I just told you, maternal immunization provides dual protection, active immunization to the pregnant woman and passive immunization to the newborn baby against the vaccine preventable diseases. Ideally, all women of reproductive age group should be immunized pre-conception. Will be born congenitally malformed, or the measles or mumps or rubella will actually infect the fetus. It has not been seen, though there is a theoretical risk. So we would tell the mother that she can continue pregnancy safely and should not panic for termination. Okay, so this I need not, since morning maybe everybody must be talking about this. So in this slide, we just want to tell that all these vaccines can be given except for MMR, varicella and BCG because it can infect the mother and the fetus. Okay. Again, the same, I won't be touching. Dr. Sneha, you made my half the slides skip. I'm going to skip half the slides now. I think it was good that I came a little late and your lecture was before me and it has made things easy. So, she also talked about Tdap and TD vaccine. So, Government of India, we are getting TD only. We are not getting acellular pertussis vaccine, which is an addition, which is Boostrix, which we talked about earlier. But what we, because it is not available, if the patient comes privately, then if she wants Boostrix Tdap vaccine, we can give her vaccine. But in what we have in hospital supply, it is TD only. We are not injecting acellular pertussis to the mother. Okay, so whenever she comes first time, you are supposed to give TD first dose, and minimum interval between the two doses should be at least 4 weeks apart, as a general rule for most of the vaccines. And booster, when to give the booster? If it is like the TT, if it is less than 3 years, the second conception.
in a private practice, if the patient wants influenza, if she is somebody who is prone to infections or she's traveling to an endemic area, then you can give her influenza vaccine. Okay. It also gives benefit to the baby. So these are again special situations for the mother. Okay, hepatitis B you can offer to the mother if she is negative on routine screening, as we are doing all in antenatal women, or if she is HIV positive, or in women whose partner is positive, or high risk behavior is there. Hepatitis A, if she is a known case of chronic liver disease or there is a travel to endemic area, same holds for like in a normal woman. Pneumococcal and meningococcal are given to women who have undergone splenectomy. They are to be repeated every 5 years. So a woman who has undergone a splenectomy and has become pregnant, generally they are advised by the hematologist, they are already on that, and if she has missed her dose, you can easily give her. That's not a problem. Rabies, post-exposure prophylaxis, there is no contraindication. And typhoid also if she is planning to travel. COVID vaccine, I'm not talking much about it. I don't know if it has gone or ever come back, I don't know. So we must have all read about it. So I'm going to skip these slides. We all know COVID vaccine can be given in pregnancy, so if it comes again, they can have it again. So we know that live attenuated vaccines are avoided in pregnancy, like MMR, HPV, typhoid, oral, cholera, Japanese encephalitis flag are contraindicated in pregnancy because they cross the placenta and pose risk to the fetus. So any contraindication in postpartum period for any vaccine? Anybody? No contraindications. It is like an adult vaccine. If she has taken one dose of one vaccine which is live attenuated prior to pregnancy, she can complete the second dose after delivery. So it is like a normal adult vaccination. So any doubts in vaccination in pregnancy? See, before we need at least 4 weeks for immunogenicity. You know that before the baby is born. Otherwise, it will not be beneficial to the baby. For mother, it will be, of course, but baby will not benefit. Like if she is delivering at 37 weeks and the vaccine has been given at 36 weeks, the benefits will be lesser to the baby because for immunoglobulins to form antibodies, it requires at least 4 weeks. Then baby benefit will not be there to the fetus. Okay. Anything else? Nothing much to remember in pregnancy. No live attenuated, Tdap and TD. And special situation, you can give rest, which I had enlisted. Okay. So let's move on HPV vaccine. So there are two main types, 16, 18 we all know, and there are which causes 70% of cervical cancers, and 6 and 11 are for the warts. So vaccine, HPV vaccine has a benefit of quadrivalent HPV vaccine will have the benefit of high risk HPV, which is carcinogenic, and also for the warts. So you know that HPV is the commonly sexually transmitted infection, can occur even after single sexual activity. Persistent infection, oncogenic HPV, can lead to development of cervical, anal, penile, vaginal, vulva, oropharyngeal, usually after several decades. So because HPV can be easily shed off and immunity can work, and it may not become a persistent virus. So it depends on the immunity of the body, whether in some patient it may persist, and 1% patient whomsoever it can persist in 10% of women, and one woman or men whatsoever, but in only 1% it will cause cancers. So whatever, all HPV infected women may not develop cancer. Okay. So you don't have to panic if somebody's HPV report has come positive. Okay, so men are also being, investigated for having HPV infection. In India, also the prevalence is quite high. And in women whose spouses, in women who have cervical cancer, the spouses, the HPV prevalence was very high, it was 66.7%. So it means that all women, when you give vaccination to women, men are also protected. And men also require vaccination. This vaccine, HPV vaccine, is not only for women, it is for men also. But generally we talk about women and girls immunization. We don't talk about men, but men also equally need it. So, have you heard about Servavac? Who has produced it? Bharat Institute. So, that has produced it. So, what is special about this vaccine is that you have to be initiated between 2,000 to 2,500. But if you're getting a mass vaccination done, you can contact them, they will give a discount. Like if it's for a school or an institution, definitely there will be some discount on it. So if you're planning to give it to some cohort of girls, then they will give it cheaper. Okay. No, I'm sorry, I keep scrolling the mouse. Okay, so advisory also says after 9. For Gardasil, they say between 9 to 12. After 12, the dose. So there's a slight variation of 2 to 3 years for Gardasil. Okay. So we talked about that. It also protects against anogenital warts and 16-18. Okay. So this, you're not only protecting cervical cancer, you're protecting a whole lot of cancers by giving just that vaccine. Okay, we talked about this. So you know about community medicine, people will know this better, what is primordial, primary. And I had to read it. So difference between Gardasil. Are you aware about the differences between the Gardasil 9 and Servavac? Cervarix is out because it was bivalent and did not help in protection of the warts. So anybody can tell me differences in these three vaccines? Strains are different. We have 9 strains in Gardasil 9. Gardasil and Servavac are similar, they are quadrivalent. Any other difference? Cost is a difference. Age group, I told you, age group slightly different. Another difference is there. No, strains are similar. It is quadrivalent means 16, 18, 6, 11. Anyone else? We're talking about age also. In my slide, there is something written in the last line. What is that? What is that? See, Servavac Indian guidelines say that because we have so much of people to cover, they say up to 25 to 27 years you cover the adult population. But in Gardasil, cover up the people who are more at the risk of acquiring HPV infection. That is the young reproductive age, below 26 years. Though it can happen at any age when they are exposed to HPV. Okay. You can see you can read the last line. HPV vaccine are not licensed for use in adults more than 45. The maximum upper limit for vaccination is 45. नहीं कोई बात नहीं बाद में ले लूंगी अच्छा आप इतना बोल रहे हैं तो दे ही दो करना नहीं वो कोई बात नहीं तो सब गीले हैं such a great host we have. Thank you. Okay, so what was my question? The speed communication, I forgot. Okay, so if the woman has come with an HPV report, women who were giving placebo, difference was 9 to 7%. So much is the protector. Those women did not get 60, 18 and did not have Asper's. Asper's, you know, it's a PAPS. So again, this shows that when it comes to protection against the precancerous lesion, that is also there. Plus the progression of the disease, higher grade of pre-malignant lesion is also protected. So the severity of the disease which requires will also reduce. Okay, so you get that the second box because the first partner itself can be infected. So if the woman says that why are you offering me HPV vaccination? I'm in a monogamous relationship, but that doesn't mean the male partner may be already infected. Okay. The cost of immunization is less in most of the adolescents because why we target that age? Because overall health cost will be reduced because we just need 2 doses. Okay. Immunizing before exposure can give highest possible efficacy against all 4. Otherwise it won't. So these are the guidelines. It can be given to postpartum and breastfeeding women, no contraindication. If she comes to you after, if she's lactating, you will not say that once you stop lactating, we'll give you vaccine. You can give it right away. It doesn't get secreted in the breast milk much. HPV vaccination can be safely given. This is all. Breastfeeding is not a contraindication. So it's the answer. We're not talking about this. So what are the contraindications? Okay, so I'll give you a scenario. Like if a woman has received Gardasil previously, now she says it was very costly, I can't afford the second dose. Can I take Indian version Sarvacus? What? How many say yes? How many say no? Only one yes. 2 yes. Rest say no. No, you have to take Gardasil. What is the other people's opinion about it? What do you say? You know, both have 4 strains, right? So what is the problem? You can still give. You can give it. Okay, you can give, because anyways it's costly. It's 1,000 rupee more than the Indian vaccine. She says, now we have an Indian made, why do you want me to take Gardasil? So you can give her Sarvac. And vice versa also. Now, if the woman, if a woman or girl has received Gardasil, she has received Gardasil, but she says, no, I wanted Nonavalent, I wasn't aware. So, what do you say? Rest are not answering, they are closer to, so they are answering. What do you say? She realized that she's taken a lesser efficacious vaccine, doesn't cover all these strains. We have a better, you can? Of course. Yes, yes. Yeah, that is there, and of course then she will be protected against all the 9 strains. You can give. Okay, so another situation, I will know whether you've understood PPT or not, is that a girl has received, a sexually abused girl is there, who's 9-year-old. The social NGO gets her to you that she must be vaccinated because she's into this profession. So what do you advise her? She's 9 years of age, I don't think. Sexually abused. Anybody can answer? Saram. Has a 9 years here. Everybody should say yes. Of course, 9 years is the age, isn't it? She's 9. So, 9 plus, so 9 plus. How many doses? Second question. There you go wrong. A sexually abused girl will have 3 doses, even if she is 9 years. Even if she's less than 12 years, we said 12 and 15, 2 different guidelines. Even if she's less than 12 or less than 15, she will still need 3 doses. Now why? Because it's not about exposure. Everybody has equal rights to exposure. It's really, I'm so sorry. You didn't hear my question? That was my question. I haven't given yet. So, how many say 2? How many say 3? Up to 50. So, why? Okay, now, if the answer is 3 doses, okay, we come to that. But why 3 doses? Because we just read the guideline 9 to 12, good immunogenicity, we are supposed to give 2. Why in a sexually abused child we are giving? Risk of what? Because of the immunity. Immunity comes into question because a child who's getting sexually abused may harbor other STDs and HIV. So, in a child who's sexually abused or a chronic or a child with chronic illness, or a child who's having multiple, this sexual relations, or a child who's HIV positive, even that age group under 12 will receive 3 doses. Okay, so we're done with that. Okay, another situation, like if a 11-year-old girl is supposed to receive 2 doses, right? She received 1 dose and second dose because she had to fly to US. and she received second. She thought I'll take a month prior, a dose a month prior. Like she took it at 4th month because she had to fly. She thought I'm going to finish my schedule. So, is it okay? According to the certificate, she's got 2 doses. She's fully vaccinated. Do you agree she's fully vaccinated? How many say no? So many voices and hands are only few. Okay. So, why no? Didn't get it. So for a proper immunogenicity, second dose is what? We consider it as a booster dose to the prior immunoglobulins, right? So when the interval has been set for 0 and 6 months, that means it has to further boost up the immunogenicity which the first dose have given. So the minimum interval has been set to 0 and 6 months because the booster dose minimum interval has to be to 6 months only. Okay. So what is the plan for that? I wish he would have given me water instead of tea. I'm just joking. So what is the plan for that? She says I won't take 2 because I've already finished. In the guidelines she's showing that I've finished already. What is the plan for her? Ask her to? She requires 3rd dose. She will require 3rd dose. And when should that be? And the gap should be 6 months. Okay. नहीं देखो 2 dose का मतलब ही है because immunogenicity will keep on happening. What is the role of booster? Sure, I'm finished. I'm done. I have nothing to talk. That may be the last slide. Okay. I was giving them because we interact with patients now, so I don't need to teach this because you're going to be in the community. Such things will come up to you. I don't know, everything else is in the books. I thought I'm going to discuss like that. Okay, so last question of mine. You will give her after 6 months. Okay. So any vaccine can be interchanged. And if the girl comes after 1 year, oh, I forgot the second dose. Can I have it now? No, you don't have to start. You can give her another dose after 1 year. But preferably the dosing schedule should finish between 12 to 15 months of the first dose. That is our target. Because now recommendations are coming that women who have, you must be knowing the storage, no? And all those things. I don't need to tell you. These therapeutic vaccines are also coming, but we need not talk about it. So, this I wanted to tell you that even there have been studies in the countries where the girls only receive 1 dose and they are quite well protected. So, studies are going on about single dose also in young girls because they have good immunity. Even 1 dose may suffice. Okay, so SAGE guidelines are there for single dose also. So, that's my summary. And there is nothing much to conclude, so I'm done. Thank you so much. If anybody has questions, but I think I have asked so many questions.
Yes.
We won't have any.
Anyone has any questions? Yes.
If somebody has any parts or
can receive the vaccine. But yes, of course they would. Because what's also so many HPV viruses cause. You don't know which virus is it. Even HPV 1 and 2 also cause warts. So that you can still give. And she will protect her against other cancers also, as we talked. She doesn't have cervical cancer, so she will be protected. So not a contraindication.
Any other question?
I'm tired of answering my question.
Thank you so much, ma'am. It was a very, very insightful and enlightening lecture, and especially on such an important topic, which is female and in pregnancy vaccination recommendation. This would also help us in, thank you for equipping us with the knowledge to enhance the maternal, adolescent, and child health. Okay, thank you, ma'am. May I please request Dr. Sneha to felicitate ma'am with a memento? Additional Professor, Center for Community Medicine, AIIMS, New Delhi. Ma'am has extensive experience in undergraduate and postgraduate medical teaching.
Most of them know me also.
Okay, ma'am. Ma'am would be giving a lecture on vaccination in geriatric population.
So, very good afternoon to all of you. I've been given this topic of immunization for the geriatric population. So you see, we have so many, priority groups: pregnant women, young children, young adults. Do you think it is important or worthwhile to immunize geriatric population? Yes. Why? Why do you think so? So I think this is a very familiar slide. Any talk about geriatric patients or persons starts with this slide, right? The numbers are increasing all the time, right? And the proportion is, we are already nearly 8%. The geriatric population is almost 8% of the entire population. And what is important is the projections show that there is going to be a rapid increase in the proportion of the geriatric population. But do you think this is enough justification that we have great numbers, so we should immunize them? Or there must be some other reasons as well? Yes? What? So if you look at this, we are even ready to surpass many Western countries as far as the proportion of elderly people is concerned. Okay? But we do have another comparison with the Western world. Dekho what is happening. 48% of our elderly are women. Many of them, nearly 75%, live in rural areas, and this is the data from HelpAge India. And many of them are below the poverty line. And just about the population of UK, our elderly go empty stomach. And approximately 50 lakh live alone, which is approximately the population of Australia. And by 2040, it's going to double. Now, is this a reason for, does this make a case for immunization? उनको हक है, very nice, very good. उनको भी बीमारी से बचने का हक है. All the more because they are with this statistics. You see, they are much more vulnerable also, right? They are much more vulnerable. So we need to protect them. At the end of the life, the quality of life does matter, right? So I want to say that a quarter of our elderly feel, this is the data of National Sample Survey, that they are ailing. They are not well. Okay, and this is important. This is worrisome, that they are ailing. Now, what is it that ails our elderly? This was a paper which was published in Lancet, The Burden of Disease, which compares, high-income countries versus low-income countries. And if you see, the burden of non-communicable diseases is high in low-middle income countries as well as high and middle income. We don't have a pointer here. High and middle income countries. Okay, I needed a pointer. Can we have a pointer here? No. Okay, that's all right. I'll manage like this only. But if you look at the infections and communicable diseases, you see the low and middle income countries, they have a higher burden as compared to high income countries, right? Now, even this is the global burden of disease. And you see that amongst the 7 most common diseases or the problems which are the causes of disease include lower respiratory tract infection, diarrheal diseases, and communicable diseases. Okay. Now, what do you see? This is the data from the well-known Lassie study, right? So, what do you interpret from this slide? Don't look at the scale. The scale is very different. If we look at the communicable diseases and non-communicable diseases, this is 32, this is 14. But what is your interpretation or What feeling do you get with respect to immunization of the elderly? What is the idea of mine showing this slide? What do you, anything? No answer is wrong answer here. Don't be afraid. Speak up. Non-communicable is increasing. Okay. Any other answer? This is right. The observation is right. Increasing or it is higher? It's high. But at the same time, the proportion of non-communicable diseases is also not less. Okay. So any other comment that you, any general comment, anything that you want to say? Most of the things are preventable, modifiable, very right. What else? Does that not mean that people who have not, we have much more burden of non-communicable diseases? Uncommunicable diseases are just the half, 32%, 14%. So we should focus more because we have limited resources. We should focus more on non-communicable diseases and, you know, be done with the, we don't want immunization. Does it mean so? No? What happened during COVID? I have a bad habit of walking when, you know, interacting with people. What happened when COVID vaccination was introduced? Who were the people, you know, who were at high risk or who were priority for vaccination? Children and elderly. And even in young adults, who were the people who were at high risk of getting COVID? With comorbidities, with hypertension, with diabetes. So similarly, it is equally worrisome that we have more proportion of non-communicable diseases because having diabetes and hypertension makes a person more vulnerable to communicable diseases as well. A person, India is the diabetic capital, you know, right? And if a person has, an elderly person has diabetes, he is more at risk of all such diseases, lower respiratory tract infection. If a person gets pneumonia, there are two elderly, you know, one is diabetic, one is non-diabetic, and they get pneumonia. Which person has more chances of invasive pulmonary disease? The one with diabetes, right? Similarly, herpes zoster, right? Zoster appears in severe form in people who have non-communicable diseases, diabetes, who are immune suppressed. So that is why our country, we have a double reason for introducing vaccines for the elderly, because we have a high burden of non-communicable diseases, and at the same time, in our environment, we have infectious agents, we have infectious diseases, and the elderly are exposed to infectious agents. Agreed? All of you agree now? So that is why I am talking about elderly immunization. Why should we have immunization among the geriatric population? Now, these are the implications I think we have discussed already. Burden of both communicable and non-communicable diseases is high. Immunity decreases with age, increasing the risk of infections. And this immunity has implications in terms of the number of doses, right? Because immunogenicity will be low in elderly people. So when the same vaccines, when we talk about the dose and everything, we'll have to keep in mind the immunity aspect as well. Elderly with chronic or non-communicable diseases are more prone to infectious diseases, and there is high rate of hospitalization because of all these vaccine preventable diseases like influenza and streptococcal pneumonia and other things. Now, what will happen if hospitalization is high? If a person frequently goes to hospital, what happens? Already low immunity. Very good. They are more at risk of nosocomial. So all the more important to protect them with vaccines, right? Now all of you agree that we need to vaccinate our elderly? Yes. Immunization is a viable option, right? So these are the vaccine preventable diseases amongst the elderly that are common in India: pneumococcal infection, influenza, tetanus, herpes zoster, typhoid, tuberculosis. Of course, we have measles, MMR, hepatitis, but they are they are more important in people who are at risk. But all the elderly are vulnerable to these infections. Okay, so what is the burden of vaccine preventable diseases among the elderly in India? Do we know how much streptococcal pneumonia is there? How much influenza is there? The answer is this only, the question mark. What is the reason? Why don't we have? Sorry? Right, lack of research, but do we get acute diarrheal diseases in children from research data? Your answer is right. Your answer is very right. But where do we get the data of, influenza-like illness, or where do we get the data from acute diarrheal diseases? NFHS. Okay. Thoda or? IDSP. Yes. You were saying something? HMI, yes, which gives us the data from IDSP only. IDSP means what? We have a regular surveillance of all these diseases. But do we have any regular surveillance of diseases amongst the elderly? No, we do not have. And that is why we do not have exact burden of disease amongst the elderly. I presented a similar lecture in this very lecture theatre a few years ago. And for all the vaccines that I'll be talking now, my answer was the API does not recommend yet. The CDC recommends, but the API does not recommend yet. But today we have the recommendations, consensus statements of API. Again, Dr. Sneha deserves a thanks from me also because she has made my job also very easier. So she has very nicely described the API consensus already, but because the main reason why API or any other organizations in India did not recommend, because we did not have the data. कुछ भी करना होता है we say hypertension. आप लोग अपना thesis protocol भी लिखते हैं तो the first statement is hypertension is the most public health problem affecting so many this, and that is why you are studying this, right? But how do we make a case for immunization in elderly? Because we don't have any data, right? So that is the problem. And for diseases like streptococcal pneumonia, influenza. So how do we actually diagnose streptococcal pneumonia? Blood cultures. When blood culture says streptococcal pakadna is a very less sensitive method. So even the methods that can tell us the burden are very, they are not very commonly. Who diagnoses zoster? Koi nahi karta hai na? So they are not done routinely. So we do not have even ways to collect this data, right? So that is why we do not have. But still there is something that we know. And what we know is communicable diseases such as influenza and pneumonia are globally the 5th leading cause of death amongst the elderly. Infections are a major cause of morbidity and mortality, and some hospital data that is available in as you say, research is lacking. Even jo bhi data hai abhi tak, it is from the research, right? So if we do more research, we'll get more data. So research-based data shows that yes, infectious diseases are a major cause of mortality and morbidity among the elderly, and they are responsible for a large number of hospitalizations. And we've discussed already that they have an increased risk of hospital-acquired infection. And in fact, the nosocomial infections in geriatric patients are around 20%. 20% of the elderly who get admitted, they get nosocomial infections. Now, I'll talk a little about the burden, whatever we know, right? What we know is that in community-acquired pneumonia, 35.8% of the isolate. So it's a big number, and it gives us an idea that yes, we should think about vaccinating our people because 35.8% of the isolates show streptococcal. And it was most common bacteria responsible for community-acquired acute meningitis also amongst the elderly. 23% of the patients of streptococcal pneumonia are elderly. The rates of hospitalization are high. So when we talk about immunization, we not only talk about preventing death and mortality, we also talk about preventing hospitalizations, putting burden on the health system, putting burden on the care burdens, and of course the quality of the life, which is very important among the elderly. Then, even if we have treatment, you say pneumonia ho gaya to treat kar denge, 35% logon ko hi to hota hai. Are all of you comfortable with Hindi if I use intermittently? Okay. So another problem is antibiotic resistant and non-sensitive. So we are getting strains which are not sensitive to antibiotics. So the solution is prevention, right? So we have to prevent. Secondly, large number of adults in our country, they suffer from diabetes, who then become a high risk for community-acquired pneumonia and invasive pulmonary disease. Now, this streptococcal vaccine, in some patients, it does not prevent the disease, but it reduces the severity of the disease. So, people who have received streptococcal vaccine will have much lesser chances of invasive pulmonary disease as compared to those who who have not received the vaccine, right? So if we look at influenza, in our country, the exact data of influenza is not known, because it is seen that it's a seasonal, epidemic in developed countries, in Western worlds. But there is an evidence of presence of influenza virus throughout South Asia. And there is an unrecognized burden. The seasonal influenza spreads as epidemics, and it affects 10 to 20% of the population. So it causes severe illness. And again, as I told, high-risk groups are people more than 65 years of age with chronic lung disease, renal disease, and immunosuppression. So, of course, it has complications such as bronchitis and secondary. Now, this is very important, that if we give streptococcal immunization, it has an added advantage in influenza epidemics, because if a person has influenza, they are more at chance of secondary bacterial infection with streptococcal, right? So if a person has received streptococcal pneumonia, even in an occasion where there is influenza epidemic, they will be protected against lower respiratory tract infection with streptococcal pneumonia, right? Tetanus. Do we ever think that tetanus is a problem amongst the elderly? Yes, it is, and more so amongst children. Why? Because the immunity wanes over time. And in our culture, we do not have the practice of revaccination of the elderly. In developed countries, tetanus is a disease of the adults and elderly, right? It is recognized as a disease of the adults and elderly. But in our country, we do not bother. We do not bother that immunity is there or not. So what happens in elderly people, they are also more prone to falls and injury. So that is why it is relevant to immunize them with tetanus. And next important disease is herpes zoster, because as the age advances, the cell-mediated immunity decreases, resulting in increase of reactivation of herpes zoster, and approximately 25% of elderly suffer from herpes zoster at one point or the other. And besides the skin lesions, the more important and worrisome complication is post-herpetic neuralgia, which is very, very painful and distressing. So immunization will not only prevent the shingles or the skin lesions, it also protects against post-herpetic neuralgia. You see, nothing works in post-herpetic neuralgia except the nerve blocks, which are also temporary, and it is very, very distressing pain. So if you immunize a person for herpes zoster, you also prevent post-herpetic neuralgia. And more the age, more are the chances of and duration of post-herpetic neuralgia. Now, see, for the first time, Niti Aayog has issued a position paper in February 2024, and amongst many recommendations, why is it not moving? So amongst rush through the slides. Thank you. So for the first time in this position paper, they have emphasized on preventive immunization, like adult immunization, to deal with immunosenescence, right? So immunosenescence is unique amongst the elderly, that with increasing age, senility, immunity decreases. Now, I think this has been referred to time and again. So we have Indian guidelines for adult immunization, and based on the age, we have a list of vaccinations. And as far as elderly are concerned, for some vaccines, we consider more than 50 years of age, for some more than 65 years of age. But nonetheless, the recommended vaccines are influenza vaccine, the pneumococcal vaccine, shingles or herpes zoster, DTaP or TD, depending on hepatitis B, respiratory syncytial virus, COVID-19 in the phase of epidemic. And now, in nutshell, I have just compiled this, that these are the vaccines: influenza, pneumococcal, zoster, TD is recommended routinely, respiratory syncytial virus, and Hib. So influenza is an inactivated virus. We do have a live attenuated vaccine also, but that is not recommended in the elderly. In the elderly, more than 50 years of age, it is inactivated vaccine or recombinant trivalent and quadrivalent vaccine, which is recommended. It is to be given intramuscular 0.5 ml annually. Pneumococcal, we have two types of vaccines, unconjugated and conjugated, which has 23 strains, and unconjugated has 13 strains. 0.5 ml intramuscular. Now, PPSV can be given intramuscular or subcutaneously, but the dose that we follow in India is recommended to be followed as one dose of PCV13 followed by PPSV 1 year later. Zoster is 0.5 ml, two doses, 2 to 6 months apart, but there should be a minimum gap of 4 weeks. So it can be given subcutaneous, and in people with not enough muscle, it can be given in the anterolateral aspect of the thigh as well. Now in India, we recommend TD, that is diphtheria and tetanus toxoid, 0.5 ml single dose, which should be repeated after 10 years, and again it is to be given intramuscularly. Respiratory syncytial virus is recombinant vaccine. It is we have two types of with or without conjugate, I should have written, sorry, typo. So 0.5 ml single dose intramuscular, and Hib also, lyophilized scaled conjugate vaccine, 0.5 ml single dose, but the first four are must vaccines for the elderly. Okay. Now, other vaccines are this, which are to be considered. Hepatitis B is also recommended, but these are the other vaccines which are considered, and TB and HIV are new vaccines. This is under trial. So these are the challenges I think we've already discussed. There is a lack of data. We have economic and financial issues, attitudinal issues, because we do not have demand for elderly vaccines. We need simplified, valid methods of obtaining data, research, and raising healthcare providers' awareness. Now, this is an important point. What happens is many times vaccines are available, but the healthcare providers are not aware of the vaccines. So, not everyone comes to the government sector. Many go to the private, and sometimes private are more aware, government are not. So, this is all about immunization in the elderly from my side. Thank you. And yes, as you rightly mentioned, everyone has a right to health, equal quality health care. Thank you so much. Any questions? I don't think.
Anyone has any questions related to the lecture? Anyone attending it online has any questions? Thank you, everyone. Thank you so much, ma'am, for giving us in-depth information on this topic and explaining it in such an interesting way. It is one of the most vulnerable groups, and at the same time, vaccination in elderly is one area in which we all have knowledge gaps, and this was a very informative session. May I please request Shalini ma'am to felicitate ma'am with memento. For the next lecture, may I please invite Dr. Rinku Sharma ma'am, Joint Director and Head, NCV BDC, DGHS. Ma'am has done MBBS and MD Community Medicine from Lady Harding Medical College, New Delhi. Ma'am has also done postgraduate diploma in mental health and fellowship in palliative care. Ma'am would be presenting a lecture on malaria and dengue vaccines and others.
तो मैं मार ये ऑन नहीं हो रहा फाइल अटक फाइल क्रैश कर PowerPoint देख लेते हैं
Thank you. So, good afternoon, everyone. And I would like to thank the organizer for giving me this opportunity to giving the recent update on the malaria and the dengue vaccine. So, myself, Dr. Rinku Sharma, currently working as a Joint Director at National Center for Vector-Borne Disease Control. At NCVBDC, we actually work for the implementation of the National Vector-Borne Disease Control Program, which includes the the 7 vector-borne diseases: malaria, dengue, chikungunya, Kala Azar, filaria, and J, and some surveillance for the Zika as well. So, through my presentation, I will make you to go through the epidemiology for the malaria and dengue, chikungunya, especially dengue, and what is the current status of the malaria and the dengue vaccine, and what are the challenges in development for these vaccines. So, if we this is the progress regarding the malaria that is in our country. So the malaria is targeted for elimination by 2030. If we look into the as per the definitions, we have categorized the whole country into four different categories. Like the category 1, where there is a 0 indigenous cases. Indigenous means no cases has been reported locally. It may be imported from other state or from other country. So category 0, where the state and UT with the 0 cases in all the districts. Category 1, where the API, annual parasite incidence, which is the number of new cases per 1,000 population, At the state level, it is less than 1, but in all the districts also it is less than 1. So then the state is under category 1. Category 2 is state having API less than 1, but some of the districts may have API more than 1. And category 3 where the state level API is more than 1. So this is the progression of the epidemiology of malaria from 2015 to 2023. So currently, if we look into in the country, three states reported 0 indigenous cases. There may be some imported cases, and the category 1 there the 24 states and UTs are there. In category 2, 7 states, and category 3, 2 states, Mizoram and Tripura is there. So this is the progress of the malaria cases and deaths since 2015. So currently, last year we reported 2,27,564 cases along with 83 deaths. And this is the update by 2024 April cases. Till April, we have 26,254 cases along with 2 deaths. The epidemiology is important that for consideration why the malaria vaccine should be introduced in India or not. So this is the trend of API. The earlier in 2015 when it was 0.92, now it has come down to like 0.16 in 2023. So we have achieved 80%, almost 80% reduction in cases in 2023 in compared to 2015, almost 78% reduction in deaths in 2023, and the success of malaria has been applauded by the various World Malaria Report as well in subsequent 2018, 19, 20 and 21. And as of now, by 2023, 122 districts reported 0 malaria cases, and 52 districts reported 0 malaria cases in 21 to 2023. And because the national strategic plan, which was like 2017-2022, has been ended up, so the new strategic plan has been developed for how to reach the malaria elimination by 2030. It means for achieving the malaria elimination by 2030, we have to achieve the 0 indigenous cases by 2027, which need to be maintained for next 3 years. So this is the goal of the new NSP is to achieve 0 indigenous cases throughout the country by 2027, eliminate malaria by 2030 in entire country, and help to like the environment which prevent the re-establishment. Also, we need to work on the re-establishment of the malaria from the other neighboring countries which have which may have malaria cases. So these are the key strategies. So I would not go into that in detail. Now the dengue. If we look at the epidemiological situation of dengue in our country. So since you must have learned the major outbreak in 1996 in Delhi. After that, the cases are continuously rising. So as of now, if we in 2023, as per the reported cases, under the program we only take the confirmed dengue cases which is diagnosed through the ELISA IgGM or ELISA NS1 antigen. So based on those tests. If we look, the last year we have reported 2,89,235 cases, and with a case fatality rate of 0.02. The national target for case fatality rate is less than 1. So as of now, we have achieved the case fatality rate of less than 1, and at national level it was 0.02. But the WHO has warned about like in 2023 and 2024 because of the El Nino effect, there may be rise in the number of cases, and also we reported last year also large number of cases and deaths. These are the strategy for dengue and chikungunya prevention. Like the surveillance is one of the important strategy through which we are able to know the actual number of cases across the country. Case management, various guidelines has been developed for the case management till the peripheral level at the PHC, CSC in the district hospitals. Vector management is one of the integrated part for the dengue and chikungunya prevention and control. Outbreak response, capacity building, behavior and change communication, intersectoral coordination. Without the involvement of other non-health sector, it is not possible, and monitoring and supervision. So these are the some strategies. These are the like the sentinel surveillance hospitals network through which the early diagnosis and diagnosis is done for dengue and chikungunya, along with the network of the 17 Apex reference lab across the country. So malaria vaccine, what is the rationale and the use? So as per the United Nations Sustainable Development Goal 3, we have to ensure the well-being and promote the healthy livings. And there should be a 90% reduction in malaria incidence and mortality, and malaria elimination in at least 35 high endemic countries by 2030. So India is also one of the high endemic country and has a target for malaria elimination by 2030. In October 2021, WHO approved first malaria vaccine, which is AS01. AS01 is the adjuvant, and all the brand name is the Moscow risk, to immunize the children in the region with moderate to high transmission. So moderate to high transmission definition is where the API, annual parasite incidences, 450 and above, and moderate transmission of API where 250 to 450 API after successful piloting the 4 African countries. So this is the rationale for having malaria vaccine in the country. So on January 2024, Cameroon began to roll out the RTS vaccine under their national immunization program. And last year in December 21, the WHO also has pre-qualified another vaccine, R21 Matrix M. Matrix M is a adjuvant to this. And the phase 3 trials of the R21 Matrix M showed the efficacy for time, which has resulted in the for the countries where the transmission season is more frequent, the efficacy is 75%, and where the annual transmission is more frequent, the efficacy is 68% in the children 5 to 36 years of age group. So if we look at the global burden of the malaria, so as per the World Malaria Report 2023, 249 million malaria cases has been reported across the world, and the Southeast Asia region under which India lies, they have reported 2% of the malaria cases. And as per the national program, India has reported in last year 2,27,564 cases and 83 deaths. If we look into this scenario, so maximum burden of the malaria cases in the African countries, and which contribute almost 94% of total cases, and the mortality in under 5 is almost all malaria deaths. 80% of all mortality in African countries is less than 5 years. So from here we can look into the malaria vaccine, which is approved by the WHO, is to be implemented firstly in those high burden countries, especially where the transmission is high and moderate. And high and moderate, we have given the definition where the API is more than 450 and the API is 250 to 450. So, as per the current scenario, the malaria vaccine is not, because our country has the API 0.13. So, as per the current scenario, it is not recommended, or the various deliberation has been done. So, malaria vaccine is not currently being implemented in India, but it is given in the high burden countries for African, where the pilot testing has been done, like Ghana, Kenya, and Malawi. And it has been rolled out in other African countries as well. And the efficacy, if we look into, it has already been administered, the RTS vaccine has already been administered to 2 million children in the pilot studies in Ghana, Kenya, and Malawi, and has resulted in 13% reduction in the child mortality. In our country, maximum number of cases, जो अगर हम less than 5 years के देखें, the death due to malaria is only 15 to 20 deaths, which has been reported in less than 5 years. So considering malaria vaccine in our country need more deliberation. So these are the two vaccines, RTS, which is the monovalent recombinant protein vaccine using the circumsporozoite protein of malaria, sporozoite, and approved by the WHO in 2021. It is a vaccine with the initiative of PATH and the GSK, and with the support of Bill and Melinda Gates Foundation. 4 doses are to be given in the children of 5 months of age, and 5th dose need to be given 1 year after the 4th dose. And it is helpful. The malaria vaccine is helpful in reducing the severe malaria cases, in reducing the hospitalization, and also reducing the deaths due to the malaria. So the vaccine is against only for the P. falciparum, which may cause the severe malaria, not for the PY-Vax. The next vaccine, R21 Matrix M, which is also a recombinant protein vaccine. It is being developed by the Serum Institute of India with the support of University of Oxford. It comes in the 3 doses, need to be given in 5 to 17 years of age group, and 4 doses need to be given after the year of 3rd dose. It also helpful in reducing the hospitalization, severe and malaria, and the child mortality due to malaria. So different types of vaccines are there. I just give a brief detail about it because you know the malaria parasite goes into the different stages like pre-erythrocytic, erythrocytic, and the transmission from human to mosquito. So the pre-erythrocytic, erythrocytic, and transmission blocking vaccine. So both RTS and R21 matrix vaccine are pre-erythrocytic vaccine. And these are the best vaccine which attacks early stages of and completely block the development of the subsequent stages. So I think I would not go into the details because these vaccines helpful in inducing the antibodies as well as the CD4 and the CD8 response into in the individual. And the viral vectored vaccines are where the adenovirus are being used both for the pre-erythrocytic cycle as well as erythrocytic cycles, and they are helpful in the attenuations of these they use the several antigenic inserts both from the pre-erythrocytic stage and the blood stage, which shows the encouraging efficacy. The third vaccine is the cell traversal protein antigen of hookanates and sporozoites, which helps in prevention of transmission from human to mosquito of the infected or the gametocytes. From gametocyte prevent transmission from human to the mosquito, which and helps in reduction of transmission of infections in the community. So this is at the community level. If we combine both the vaccine, pre-erythrocytic, erythrocytic, and the transmission block, then it will be more helpful in reducing the transmission at a community level. What are the challenges in the malaria vaccine? Because we know the malaria parasite has a extremely complex biology. It has a different stages, asexual, sexual stages. Even in the in the human body, it goes into the different stages of life: sporozoid, virozoid, then gamete. So against which complex or against which component we have to develop the vaccines? Complicated life cycles, immune escape mechanism is also expressed by the different parasites. For the pre-erythrocytic, also we are using 1%, less than 1% of the parasite antigen for development of the vaccines, and targeting erythrocyte. Once the merozoites are released, which are more in number as compared to the sporozoites, it is difficult to target them. So targeting erythrocyte is difficult because of the antigenic variation, and they can easily evade the immune response. Another challenge is to having a dormant hypnozoites in the liver stage for the P. vivax and the P. ovale, which is not tackled by any blood stage vaccine. And moreover, there is this species specificity. Most of the P. falciparum, the P. vivax species, they do not infect the animals on which the vaccine trials are done. Vaccine evaluation is done. And malaria mainly affect the countries because we are mainly the resource limited countries. So it is not given any little motivation for the companies who are investing a lot in the vaccine trials. So whether the malaria vaccine is a reality for really an option for the India. So if we look at the transmission and the API, if we compare it as 0.13 for our country and the high transmission, like for the African country, they come into the moderate and high transmission. And target population are children. अगर हम अपनी malaria population में देखें number of cases and deaths, which is quite less as compared to other like the African countries. Malaria vaccine prevent only the severe malaria. As we seen in our previous slides, 60% of currently, if we look into the scenario of malaria in India, mainly the malaria it is concentrated in the tribal population, where the P. falciparum is high and the P. vivax is low. But this is not the distribution is not same across the country. So we need to have more studies to identify the various in the heterogeneous distribution of the malaria cases in our country. We need more research, more epidemiological gaps are there which need to be filled up before having some malaria vaccines in India. So malaria vaccines require more immunobridging studies based on the vaccine which have already been approved by the WHO. India has a low transmission intensity. So because transmission is less, though vaccine efficacy will ultimately be poor if we introduce in our country. So, and moreover, these vaccine has currently not been approved by the DCGI. So, this is a limited option as of now in our country. So currently, whatever vaccine has been approved for malaria, it is being used, and because of the limited production also, first the priority is given to the African countries or the high burden countries where the 94% of all malaria cases are being there. So currently, it is not an option as of now for the our country. If we look into the dengue vaccine, as all of you know that the dengue has a 4 serotype, Den 1, Den 2, Den 3 and Den 4. All are circulating in our country. And basically, I just want to highlight over here the ADE response, antibody dependent enhancement report, because the vaccines which has been used in our other country, they have a little like complications in the person if they have been administered to the dengue naive patients. So, dengue, what is the antibody enhancement, antibody dependent enhancement? Whenever you have any, you must have known the first clinical infection with one serotypes gives the lifelong immunity, but little cross protection for the other serotypes. So whenever there is a second time infection, the chances of the severe dengue infections are quite often as compared to the first and third and fourth subsequent infection. So what happens whenever you have a first infection with the dengue virus, there are some antibodies are there. Whenever subsequent infection comes, so it helps in the virus entry and more virus release in the subsequent infections, which is known as ADE, and lead to the more severe infection whenever you have the second time infection of the dengue virus. So these are the different vaccines are available, like Dengvaxia, TV003 or TV005, which is the National Institute of Health vaccine, and TAX003, or which is also known as Qdenga or Dengvax. So currently WHO has approved the 2 vaccines, Dengvaxia and Dengvax, to be used, and it is being used in like European region and also the USA's. Other like 20 countries are using this. So the Dengvaxia, which is it is a recombinant live attenuated vaccine, so where the yellow fever virus backbone has been used, and the pre-membrane and the envelope protein of yellow fever has been replaced by the homologous genes from each of the dengue virus. So Dengvaxia, so these are the structural detail. I think we may not go much detail into this. These are the efficacy trial of the dengue anti-dengue vaccine. If you look into the Dengvaxia, Dengvax, and TV003 and 00500 virus, so maximum. If we look into the Dengvaxia, so the maximum seropositivity is in the Den 4. It is decreasing for Den 2, and overall efficacy is 30 to 60% in all the patients, including seropositive and seronegative. So one of the important prerequisite for introducing these vaccines to have a serosurveillance of the whole population, because it has been seen if we introduce these vaccines, we administer these vaccines to the seronegative individual, those who do not have any infection of dengue previously, do not have any exposure, the severity of the disease is quite more in those. This is because of the ADE reaction that we have explained earlier, because of the antibody dependent enhancement. The severity after this administering these vaccines are quite severe in those who do not have any previous exposure of the dengue virus. तो जिनमें पहले डेंगू हो चुका है, अगर उसमें ये वैक्सीन एडमिनिस्ट्रेट किया जाए तो उसकी एफिकेसी उनमें ज़्यादा होती है एज कम्पेयर टू दोज जिनमें वायरस का इन्फेक्शन नहीं हुआ. क्यों होता है ऐसा? क्योंकि जिनमें इन्फेक्शन नहीं हुआ है तो डेंगू वैक्सीन वायरस will act as the first time of infection, and whenever subsequent infection occurs, it is the second time infection, which lead to the ADE reaction and the more severe reaction to those patients. So the overall efficacy of the Dengvaxia is like 30 to 60%, and seropositive is 74 to 83%, and efficacy in seronegative is less. Only the Dengvax vaccine, like the second vaccine, it's quite efficacious, like the Dept vaccine is quite efficacious in those which are seronegative. तो ये ट्रायल से हमें पता चल रहा है. तो so if we look into the dengue vaccine status, World Health Organization has approved Sanofi Pasteur's Dengvaxia in the 20 countries including USA, Europe, for use in the individual above the age of 9 years. with a laboratory confirmed previous dengue infection. उन्हीं में देनी है जिनको already पहले dengue infection हो चुका है. उनमें जिनको dengue infection नहीं है उनमें नहीं देनी है. Tech 3, which is has been developed by one of the Japanese company, Qdenga, for use among the children 6 to 18 years, where the high transmission is there. So this vaccine is also like a candidate vaccine to be introduced in India, but it also at the same time we need to have a zero surveillance of our population to introduce these vaccine, because both the vaccine, the seropositivity status need to be known ahead before giving this vaccine. So some of the trials are also has been conducted in the country, like the tetravalent dengue vaccine clinical trial in India, which has been conducted by the Panacea Biotech, and they have completed the phase 1 and phase 2 trials, and they found the vaccine is effective, well tolerated, and induce the antibody response against all serotypes. And they are in the process of conducting the phase 3 trials. The trials has also been conducted by the Serum Institute of India. They have completed the phase 1 trial, and it is based on the TV strain, TV003 and 005 strain of NIH USA. So because before introduction of these vaccine, various immunobridging studies to be done, because the demography is totally different, and it may be that we have to change the doses as well. So the immunobridging studies with the ICMR is in process for the various age group, and determining the serotype before vaccination is a mandatory for all those vaccination before the above the 9 year of age group. And one of the company from Biological E Limited, they have a they have licensed with the Takeda, which is a Japanese company, for accelerating the access to the Qdenga, which is the TK003 or 005 vaccine, dengue tetravalent vaccine, for more production, and it is hoped that by 2026 we would have some vaccine, dengue vaccine in India for use. So as malaria, the challenges is also there in the dengue vaccine. It is a very complex vaccine, 4 serotypes, and even then in the serotypes there is various genetic variation is there. And for having a good quality dengue vaccine, it should have the sustained immune response, should be and it may be given without the serosurveillance status, because having the serosurveillance study is also quite resource incentive. So before introducing, we should have all these conditions, and complexity in the dengue vaccine development, because it requires very large efficacy trials also. And some new approaches are also being done, because currently the vaccines are live attenuated. We are working on other countries, like the research organization working on having nucleic acid vaccine, viral vector vaccines, or inactivated vaccine, which can be used for the wider public use. So thank you. These are the 2 vaccines which are as of now not available in India, or not being used in India. Thank you.
Anyone have any questions related to the lecture? If anyone attending the CME online has any question, you can put it in the group right now. Thank you, ma'am, for the insightful